So good morning, everybody. It's 8:31 Central European Time or 9:31 Turkish and my Qatari time as well. Thank you, everybody, for registering and attending the 7th Bosnian Turkish Cytopathology School. I'm very happy and honored to open the 7th Bosnian Turkish Cytopathology School, which goes this year still online, but nevertheless, I hope it will be a great success. The school is, as usual, organized by the joint efforts of the Turkish division of the International Academy of Pathology, the Turkish Society of Cytopathology, and on the local level and by the Association of Basic Medical Sciences of the Federation of Bosnia and Herzegovina. This year's school is focused on gynecological cytopathology and feature distinguished and highly experienced cytopathologists and clinicians from Turkey as main lecturers. We highly appreciate the contribution of our Turkish colleagues to make this school successful. The school objectives, as usual, remain the same: to cover the most important topics in cytopathology, this year in gynecological cytopathology, and to cover the practical issues, especially those that may be relevant to young specialists and residents in pathology and clinicians as well. We are very happy to have participants from all over the world, hoping that this year's school will meet your expectations, but we also expect your active participation that will be essential to make this school a great success. Once again, on behalf of local organizers, Dr. Skenderi and I appreciate again great efforts by our Turkish colleagues, mainly by the Turkish division of the International Academy of Pathology and Turkish Society of Cytopathology. Of course, we are very thankful for our honorary president and the founder of this school, our great friend and the great Turkish pathologist, Professor Sitki Tuzlali, who has been very supportive to the school in all these years. Thank you, Sitki, very much. All right, again, now I will give the stage to my Turkish colleagues. First, on behalf of the Turkish division of the International Academy of Pathology, Professor Funda Yilmaz will speak, give introductory word. Professor Isinzu Kuzu, who is president of the Turkish division of the International Academy of Pathology, excused and was not able to attend this meeting, but has been very supportive in organizing this meeting, and we acknowledge it. So, Professor Funda Yilmaz, on behalf of the Turkish division of the International Academy of Pathology. Thank you.
Good morning to all my colleagues and all the participants. I would like to welcome you on behalf of International Academy of Pathology Turkish Division, and also for on behalf of the Federation of Turkish Pathology Societies. We are very glad to be here with you, and Semir, as Semir also mentioned, Işınsı Kuzu, the president of IAP Turkish division, is in another meeting at the moment. So I'm, as the secretary of the division, I have the pleasure to be with you. I would like to start by thanking to the founding presidents of this school, Sıtkı Tuzlalı, Semir Renik, and Faruk Iskenderi, since they are in the organizing committee from the beginning, very early beginning of this course. And I would like to also thank all the past and present presidents of Turkish Society of Cytopathology, which is making a very unique event, this meeting. I would like to thank to all our participants. As much as we know, we are more than 1,000 participants from more than 50 countries, and it is our pleasure to be with you. So I would like to thank all the organizers and wish a nice meeting, a successful meeting for today. Thank you very much.
Thank you very much, Professor Yilmaz. I will now give the word to Professor İlker Akpolat, who is president of the Turkish Society of Cytopathology. Please.
Good morning. I would like to say a warm welcome to the 7th Bosnian Turkish Cytopathology School on behalf of the Turkish Society of Cytopathology. Our aim for this meeting was to be able to come together with all of you esteemed colleagues who are dedicated to cytopathology from all around the world. I am very happy that we have achieved this goal. I would like to express my sincere gratitude to participants who have made this possible by attending our meeting from many countries around the world. Furthermore, I would like to thank the Association of Basic Medical Sciences of Federation of Bosnia-Herzegovina, Turkish Division of International Academy of Pathology, and Turkish Society of Cytopathology for their great efforts in making this meeting happen for many years. Due to their valuable contribution to this meeting, I would also like to thank the founder and honorary president, Dr. Sıtkı Tuzlalı, founders and local organizers, Dr. Semir Vranic and Dr. Faruk Skanderi, President of the Turkish Division of the International Academy of Pathology, Dr. Işın Sukuzu, and President of the Federation of Turkish Pathology Societies, Dr. Funda Yılmaz Barbet. I would like to highlight that this meeting has received generous support from several organizations. I want to express my gratitude to Becton Dickinson, Gamidor, Virasoft, and Acıbadem Health Group Pathology for their valuable contributions. In particular, Virasoft and Acıbadem Health Group Pathology have provided technical support for video microscopy, enhancing the quality and effectiveness of our sessions. Their assistance has been instrumental in enriching the learning experience during this event. Thank you to these all organizations for their dedicated support. Finally, I want to thank Optiamist for this nice organization. I hope you will enjoy and learn a lot from this meeting. Again, I want to thank all of you for your participation. Now I will give the microphone to Dr. Vranic to continue.
Thank you very much. Thank you, Professor Akpolat. Last but not least, before we start the sessions, I will give the stage to our friend, Dr. Sıtkı Tuzlalı, as a founder of this school. Sıtkı, please.
Thank you. Dear colleagues, I want to say a few words about our division, and it has been established about 9 years ago, the Turkish division of the IAP. And as Turkish pathologists, we know that we don't dominate science, but we have a very good practice, especially in medicine and pathology also. So as IAP division, our aim has been always to share our knowledge and expertise with especially the neighborhood countries, because it's an international organization. And we have too many meetings in our country in Turkish, but you can guess the aim of this should be different. And to share the expertise with each other. And as you can guess, today also, this geography has always been a difficult one, as it is nowadays. The countries around us need this much more than others. So we began these meetings, and I'm grateful to Semir and Faruk, my friends and brothers. We began together, and now there are so many attendants, and we are from very heterogeneous geographical locations. So all our societies and us are very proud now. And I think the meeting, this meeting will become a brand. We will try to develop it. So we need your feedback to develop it. So please directly write us to Semir, Faruk, and us. We will give our emails in the chat box and take your ideas. And another point, how to develop this. I think as Turkish division or IAP, we may organize practical courses also. For example, we have traps in pathology, traps in GYN, traps in breast, traps in lymph node. Lymph node itself is a trap, as you know. So we may organize such courses for these attendants if you wish. So please write us. So we are grateful to all of the speakers for their participation and sharing their knowledge. Our gynecologists are the most experienced persons for mass screening and also cervical cancer. I think it will be very nice for you to communicate with clinical data. And thanks to Turkish Cytopathology Society, Bosnian Society, and all the speakers, and have a good meeting. And please write us and demand something. Thanks a lot.
Thank you very much, Sidki. And I also support the participants to provide feedback, which will definitely help us in planning the future schools to improve it. And your feedback is really highly appreciated, particularly this year when we have a large number of participants from all over the world. Once again, thank you, everybody. Welcome again to the 7th Bosnian Turkish Cytopathology School. Once again, thanks to the organizations for supporting this meeting. And of course, thanks to our supporters that Professor Akbalat already mentioned. Just before we start the first session, for the participants, please note that we'll take all your questions. The questions for the first session will be answered immediately after the session, while the remaining questions related to the remaining sessions will be remain before the first break at noon Central European time. So feel free to leave the questions in chat box, and we'll take care of the questions and make the efforts to get all your questions answered.
Good morning. I'm Dr. Tuğba Taşkın Türkmenoğlu from Etlik City Hospital, Ankara. I'd like to thank the organizing committee for this opportunity. My topic today is liquid-based cytology for cervical cytology and automated screening devices. In my speech, after a short introduction, I will mainly cover about the technical aspects about these platforms, which are FDA approved and worldwide used. Comparing these systems and talking about which one is better or superior in any terms is beyond the scope of this talk. There are no relevant financial or non-financial competing interests to report and no conflicts of interest to declare. Cervical cancer is the 4th most common cancer in women worldwide, according to the Globacon data. In Turkey, according to National Cancer Statistics, cervical cancer is the 9th most common cancer among women. This disease is a major cause of morbidity and mortality. The onset of cervical cancer often results from a persistent infection with high-risk human papillomavirus. HPV infection can result in changes to cervical cells, which over time may become cancerous. Observations by Dr. George Papanicolaou in 1923 that vaginal cells of women with cervical cancer were different from vaginal cells from women without cancer initiated the study of cervical cytology. This lifelong work of Dr. Papanicolaou resulted with a simple test known as the Papanicolaou or Pap smear as the most successful cancer preventative test in widespread use to date. In conventional cytology, a sample of cells are taken from the cervix and smeared directly onto a glass slide. Success of the Pap smear in cervical cancer screening generated expectations that the test was perfect. In late 80s, reports of women being diagnosed with cervical cancer, despite earlier screening and of poor quality work in the cytopathology laboratories, led to intense public scrutiny. 1999 Agency for Healthcare Policy Research evaluation of the best 85 studies on the Pap performance established the sensitivity of Pap smear screening as low as 0.5. In addition to poor sensitivity, conventional cytology has a number of limiting factors. The manual procedure of applying the cells to the glass slide is impossible to standardize. Cells are distributed unevenly over the surface of the slide. Thick overlapping areas that obscure visualization of individual cells are common. Diagnostic cells can be obscured by mucus, blood, or inflammatory cells. The thickness of the cell layers requires constant focusing up and down by the cytologist to visualize the majority of cells. Cell air drying because of delay in fixation or inadequate penetration of the fixative can distort cells, making them uninterpretable. In the early 1980s, work began on improving cytology preparations by distributing cell collections in a liquid-based preservative before placing them on the slide. Much of the original impetus for this research came from the early attempts to develop automated computer image analysis systems for the evaluation of Pap smears. Liquid-based preparations were the fruits of these attempts. For many years, pathologists have worked to increase the sensitivity and specificity of the conventional Pap smear. Liquid-based cytology is a monolayer slide preparation technology. The sample of cervical cells is collected in a vial of preservative solution. The vial containing the suspended cells in solution is transferred to a cytology processor that is used to place a uniform layer of cells on a slide. Liquid-based cytology offers several advantages over conventional smears. Immediate fixation with enhanced nuclear and cytoplasmic detail. All material collected is available for microscopic evaluation. A representative sample is prepared for cytological evaluation, but multiple samples and cell blocks can be prepared as necessary. Clearer backgrounds so that epithelial cells of interest are less likely to be obscured. A thin layer of dispersed cell are spread over a fixed area so that the area to be screened is small and it takes less time to screen than a conventional smear. Unsatisfactory rate is decreased. Liquid-based cytology samples are suitable for other tests like HPV testing. Also, chlamydia and gonorrhea tests can be performed. Liquid-based cytology slides are suitable for automated analysis. And there are some disadvantages of liquid-based cytology. These are smear patterns altered because of randomization of cells, abnormal cells are dispersed, blood, inflammation, and malignant diathesis are still present but appear slightly different. Epithelial cells appear mostly as single cells and are slightly smaller than they appear in conventional smears, especially endocervical cells and immature metaplastic cells. And liquid-based cytology is more expensive than conventional tests. In 1996, ThinPrep became the first liquid-based cytology to receive Food and Drug Administration approval. It was followed 3 years later by Cytopathology, now called as SurePap. I'm going to talk about two FDA-approved systems in liquid-based cytology, ThinPrep and SurePap, and mainly about the technical aspects of these systems. Gynecological samples collected for preparation using the liquid-based cytology should be collected using a broom type or endocervical brush plastic spatula combination collection devices. The most commonly used brushes are Rover's cervix brush and rover cervix brush combi. I'm going to start with TIMPREP. TIMPREP is a property of hologic. For TIMPREP cytological, gynecological smears, TIMPREP preserved site solution is used. It's a methanol-based buffered preservative solution. It contains 20 milliliter of this solution. It can be stored with cytological sample intended for PAP testing between 15 degrees Celsius and 30 degrees Celsius for up to 6 weeks. After obtaining cells from the cervical canal with special brushes, the brush is rinsed immediately into preserved site solution vial by pushing it into the bottom of the vial 10 times, forcing the bristles apart. And as a final step, swirling of the brush vigorously to further release material. And then, after this process is done, the cap is tightened. There are 3 commonly used TIMPREP processors at the markets. One of them is TIMPREP 2000 processor. It's a semi-automated device which processes 1 specimen at a time. A newer version, TIMPREP 5000 processor, is a full automated benchtop instrument that processes specimens in batches of 20. TIMPREP 5000 autoloader system is another automated system and has a capacity of samples up to 160. After the vial arrives to the cytology laboratory, vial is uncapped and loaded in the processor. Sample vial is placed into the sample holder until the bottom of the vial rests on the sample holder base. Filter is placed onto the filter cap. Filter is a hollow plastic cylinder with a 20 millimeter diameter polycarbonate filter. The pore size of the filter is 8 microns. There are 2 methods to assemble filter and the filter cap. You can either assemble these 2 pieces in your hand or you can do it on a bench. A slight twisting motion should be used. After the filter is placed onto the filter cap, filter and filter cap is loaded. It is followed by slide loading. Slide should be placed as the label end to the right and facing down. Then the slide is pushed in until it does not go any further. A fixative bed is added. It is filled with standard laboratory alcohol until the fluid level is between minimum and maximum marks on the vial. Then the door is closed and selecting of the sequence is done. And for gynecological samples, sequence 4 is selected. The preparatory steps of the TIMPREP system are dispersion, collection, and transfers of the cells. After the operator initiates the sequence, elevator raises sample to the filter and system checks for appropriate fluid level. TIMPREP PEP test filter rotates to disperse sample material. Liquid is drawn into the filter, then pushed out. So gentle dispersion step breaks up the mucus, blood, non-diagnostic debris, and truly mixes the cell sample. Sample is drawn into the test filter in a controlled manner. The cells are collected on filter specifically designed to collect diagnostic cells. A vacuum is applied to the cylinder, trapping the cells on the filter. The instrument monitors cell density on the filter. Then the filter is inverted and sample is lowered. Slide holder contacts filter A thin layer of cells is then transferred to a glass slide in a 20 millimeter diameter circle. The slide is automatically deposited into a fixative solution and the filter returns to the starting point. ThinPrep system creates an unstained thin layer of cells in a 20 millimeter diameter circle. It does not stain the slides, and slides are stained separately in a stainer. This is a summary of ThinPrep system. The liquid-based medium is methanol-based. Head of the cervical brush does not remain in the preservative vial. It uses a filtration process. It produces a uniform layer of unstained cells in a 20 millimeter circular area. Staining is not included. Remaining material can be used for ancillary tests. You can order new slides. You can have a cell block, or HPV testing can be done. Remaining sample can be stored up to 6 weeks. The second liquid-based cytology system that I'll be talking about is SurePath. SurePath is a property of Becton and Dickinson. For sample collection, SurePath collection vial is used. It contains 10 millimeter of 24% ethanol-based preservative fluid. For sample collection, special plastic brushes are used. And after obtaining the cells from the cervix, head of the sampling device is left in the vial. SurePath works on the principle of density gradient sedimentation. It's an automated system that processes and stains liquid-based cytology slides. The main steps of SurePath system are vortexing the samples with a vortexer, cell enrichment process using BD PrepMate, and processing and staining using BD Totalis slide prep instruments. The pre-processing steps are vortexing to mix and disaggregate the sample, homogenizing the sample, layering onto BD density regions, and centrifugation. The main goal of pre-processing steps is cell enrichment. You need a vortex to vortex the sample to homogenize the sample. The multi-vial vortexer mixes up to 25 specimen vials in a clamshell at a time. Receipt vials are vortexed at 3000 RPM for 30 seconds on the vortex machine. This step allows the cells to get free from one another, and also the cell clusters from the specimen collection device are set free. Mixing and layering is accomplished automatically using PrepMate. The specimen rack of the PrepMate is loaded with a plunger, sample vial, and centrifuge tube containing 4 ml of density reagents. PrepMate density reagent is a polysaccharide solution with sodium azide added as a preservative. PrepMate automates the initial enrichment process of mixing and dispensing the specimen over the density reagents. A single specimen rack holds 12 samples at a time. This is the closer look of the PrepMate specimen rack. It holds specimen vials, seal tubes, and syringing pipettes. The syringing pipettes mix and then transfer specimen solution from the specimen vials onto the density reagent in the seal tubes. So layering is the process in which 8 ml of sample is mixed with 4 ml of density reagent in a centrifuge tube present in the rack. After the samples are processed on the PrepMate accessory, the seal tubes are manually moved from the specimen rack to the seal tube rack. The centrifuge tubes containing the sample and density reagents are transferred to the centrifuge machine inside the seal tube rack. The centrifugation steps of cell enrichment are performed to remove debris, and obscuring agents, leaving an enriched cell palette for the use on the slide prep. Centrifugation consists of 3 steps. The first step of centrifugation is done at 200 Gs for 2 minutes. This is also called a soft spin. Then the tube vac removes the supernatant. Then a second step begins. The second centrifugation is done at 800 Gs for 10 minutes. After the centrifugation, the supernatant is discarded by inverting the seal tube, and at the bottom of the seal tubes, an enriched cell palette is produced. The parts of the prep stain system are as follows. There is a computer workstation, prep stain settling chamber, robotic sample processor, and prep stain instruments. The prep stain instrument is linked to a DOS-based computer system. The software that runs the sample processor is started by typing command at the DOS prompt and then controlled using various menus. In this slide, we see the settling chambers. Settling chambers serve as a vessel to contain resuspended cellular material while they settle onto the coated microscope slides. The sedimentation of the cells onto the slide and staining takes place in the settling chamber. The major components of the slide prep are the desk accessories support rack, slide tray support with slide trays, robotic arm containing the quad arm assembly and disposable tips, and rinsing and staining syringes. Robotic sample processor resuspends the pelleted cell samples in a buffered deionized water and transfers cell suspensions settling chambers mounted on the pre-coated slides. The processor performs a sequence of washings and staining steps to stain the slides by the Papanicolaou method. The prep stain system produces a uniform layer of stained cells in a 13 mm diameter circle. Samples can be stored at room temperature up to 1 month from the collection date, or they can be stored at the refrigerator up to 6 months. This slide summarizes the preparation steps. First, the sample is vortexed. Then cell clusters are desegregated by syringing the sample. The sample is poured into a centrifuge tube filled with a density gradient reagent. Then sedimentation is performed in a centrifuge. 2 steps of centrifugation is performed. One is the soft spin. It is done at 200 Gs for 2 minutes. After the supernatant is removed, second step starts. It is done at 800 Gs for 10 minutes. And then the supernatant is discarded by inverting the C tube. And at the bottom of the C tube, a cellular cell pellet is obtained. And then the tubes are transferred to the prep stain instrument, where a robotic arm transfers the fluid into a cylinder and cells settle by gravity onto a cationic slide. In this slide, there's a summary of Schurpet system. The liquid-based medium is ethanol-based. Head of the cervical brush remains in the preservative vial. It uses cell enrichment process. The cellular material is separated by a density gradient method. The prep stain system produces a uniform layer of stained cells in a 30mm diameter circle. Staining is automated. Remaining material can be used for ancillary tests, and remaining sample can be stored up to 6 months. The second part of my talk is about automated screening devices for gynecological samples. Based on the fact that the changes in cell morphology are quite obvious, and the fact that the visual screening is very demanding, time-consuming, and expensive in terms of labor requirements, there were proposals for automating the screening through some kind of scanning and image analysis mechanism. The hope was that an automated system would be able to do the screening both at a lower cost and with higher accuracy. Automated cytology screening devices have been under development since the early 1950s. The first attempt was the cytoanalyzer in the 1950s in the USA, but in the preclinical trials, it did not perform as well as expected. The system produced many false positive rates. In Japan, in the early 1970s, the Cy-based system was developed, but it failed to produce reliable results. The difficulty of the task was soon appreciated, especially the inherent problems with analyzing smears prepared in the conventional manner. Since then, a large number of projects have attempted to develop screening systems. The problem turned out to be a lot harder than anticipated. It took more than 40 years before the first successful commercial systems appeared. And still, automated screening is not sufficiently cost-effective to completely replace the visual screening, judging from the relatively limited penetration of automated screening systems in the screening operations worldwide. A skilled and well-trained cytopathologist or cytotechnologist should evaluate the slides, which can contain up to 300,000 cervical cells. The recommended daily workload varies among countries. For United Kingdom, it's 32 slides per day, and for United States, it's 100 slides per day. Conventional cytology screening quality depends on the cytopathologist or cytotechnologist's skill and experience. As most samples contain only normal cells, the process can become monotonous and tedious for those reading them and leading to interpretation errors when abnormal cells appear. Unlike manual screenings, which are based on the cytopathologist's or cytotechnologist's ability to detect abnormalities, computer-assisted screening focuses on the professional's competence in interpreting regions of interest identified by automatic methods. The BD focal point GS imaging system and the ThinPrep imaging system are the two semi-automated systems currently used. In 1998, FDA approved the focal point slide profiler as a primary automated screener for cervical smears, followed by approval in 2002 for use with SurePath slides. In 2003, FDA approved the ThinPrep imaging system as a primary screener for ThinPrep PEP slide. Automated PEP test analysis requires executing the steps of scanning the slides to acquire images, pre-processing to establish regions of interest, segmentation to extract the relevant characteristics, and classification to rank the images into categories and present them to the cytopathologist or cytotechnologist. I will talk in details of the two FDA-approved systems, ThinPrep imaging system and BD focal point GS imaging system. ThinPrep imaging system is an automated imaging and review system for use with ThinPrep PEP slide tests. It combines imaging technology to identify microscopic fields of diagnostic interest with automated stage movement of a microscope in order to locate these fields. Prepared slides are loaded into cassettes, which are placed in the TIMPREP imaging station. Each cassette holds up to 25 slides. The imaging station scans the cell spot and sends the image to the image processor controller. The image processor controller analyzes the image and identifies coordinates of objects of interest. And then these are sent to the server. The server stores the slide data records for later review at the review scope. In this picture, the cell spot is imaged. The slide imaging system scans the entire cell spot. The system identifies any objects of interest found on the slides. The coordinates of 22 objects of interest with the highest integrated optical density will be stored in the computer's database. And this is an illustration of the review scope. Slides are reviewed by the technologists at the review scope. The autolocate feature presents the 22 fields of interest that have been identified by the imaging system. The fields are presented in a geographic order as they are located on the slides, not by any significance in ranking. Suspect cells may be electronically marked by the cytotechnologist, and a review of the entire cell spot is enforced. The slide is manually marked by the cytotechnologists. At completion, the slide data is updated with the location of any marked areas, as well as information on the review session. TIMPREP imaging system uses TIMPREP stained slides. Slide processing takes approximately 4.5 to 5.5 minutes per slide. The imaging processor acquires and processes image data from the slides to identify diagnostically relevant cells or cell groups based on imaging algorithm that considers cellular features and nuclear darkness. The coordinates of 22 objects of interest with the highest integrated optical density will be stored on the server. These 22 selected fields of view are presented in geographic order to the cytotechnologist during slide screening at the review scope. All slides that undergo primary automated screening with the image processor require manual rescreening of the selected fields of view by a cytotechnologist using a review scope. After image processing, slides are distributed to the cytotechnologists for review utilizing the review scopes. Slides are individually loaded onto the review scope stage. The alphanumeric slide accession identifier is automatically scanned, and the stored X and Y coordinates representing fields of interest for that slide are electronically downloaded from the computer to the review scope. If the cytotechnologist identifies any of these fields as containing abnormal objects, that field may be marked electronically, as we can see here. The cytotechnologist determines specimen adequacy and the presence of infections during the review of the 22 fields of view presented by the TIMPREP imaging system. At the conclusion of the slide review, electronically marked objects are ink marked. The cytotechnologist would perform a full manual slide review of each of any abnormal cases and pass them on to a cytopathologist for further review. And the next imaging system I'll be talking about is BD focal point GS imaging system. BD focal point system comprises a slide profiler, a workstation, and a review station. It has a maximum capacity of 288 slides at any one time. The BD focal point uses slides, liquid-based cytology, must first be prepared on a BD Schurpet PEP test and stained with BD prep stain. BD focal point also uses pap smear slide of conventional cytology and stain Peponicolai. The slide profiler screens the slides, classifies the slides and slide locations according to their likelihood of containing abnormal cells in category review. Slide profiler is also capable of designating areas on the slide that contain the most abnormal cells by displaying them on a printed map using PepMap technology. The review of the slides for Schurpets is approximately 4 minutes, and conventional slides it's approximately 6 minutes. The BD focal point includes a computer-based slide review microscopy station and the GS review station. The latter allows automatic localization of microscopic fields of view using information obtained from imaging system for review by cytotechnologists. BD focal point obtains digital images using a high-resolution scanner and a high-speed video microscope. These images are then analyzed by the instrument using an algorithm-based interpretation software. Imaging system includes screening algorithms for over 100 object analysis features, including both squamous and glandular algorithms to determine potential abnormality. The instrument selects 10 areas, each corresponding to one manual microscopic 10 times objective fields of view that is most likely to contain diagnostically relevant cells. Manual screening is performed at the review station. The monitor displays an electronic map of the slide indicating the locations of the 10 fields of views, as well as a low resolution 20 times magnification black and white image of the field of view. With no potential abnormalities in the 10 field of views, the slide is reported as negative for intraepithelial lesion or malignancy and satisfactory for interpretation. Full slide manual screening is required if one of the following conditions are met: abnormality on field of view review, adequacy reasons, no field of views are presented or designated for quality control review. In this slide, flow chart of cervical cytology samples using automated methods is shown. When analyzing a pap smear in a manual manner, specialists may view up to 16,000 images and up to 300,000 cells are analyzed. TIMPREP imaging system and BD focal point system can process liquid-based cytology smears. And BD focal point system also can review the slides for conventional cytology. The slides are scanned through the processor and fields of views are selected. Then these field of views are represented to the cytotechnologists, and if any suspicious cells exist at the smears, full manual review of the slides should be performed. And then the slides are ink marked and referred to the cytopathologists for final diagnosis. This is the end of my speech. Today I talked about liquid-based cytology for cervical cytology and two FDA-approved systems, TIMPREP and Schurpet, and also automated screening devices, which are TIMPREP imaging system and BD focal point GS imaging system, also FDA-approved, and the technical features of these systems. Comparing these systems with one another and which one is superior or better in any terms was out of the scope of this speech. So I want to thank you all for your attention and patience.
Dear chairs and dear participants, this is Yasemin Öztürk from Istanbul University, Istanbul Faculty of Medicine. Before I begin, I'd like to thank the organizing committee for having me here in this meeting. While you are listening to this video, I will be at another meeting at the same time. I hope I will be online during the QA session to join you. And thank you all for joining the 7th Bosnian Turkish School of Cytopathology. I will give an introduction to Bethesda system for reporting cervical cytology. And I will summarize the answers to these three main questions. Why do we use the Bethesda system, which I will call sometimes as TBS during the presentation? Why do we use the Bethesda system for reporting cervical cytology? What are the basic principles of this system? And what do recent literature data show on the performance of diagnostic categories of TBS? We know that with the help of this brush, we collect cells from the cervical epithelium, and with the findings we detect in these surface cells, we have information about the underlying lesion, whether it's a precancerous lesion or not. Cervical cancer screening is done either by cytology and or HPV testing. And also I will give a short summary of the historical perspective of this Bethesda classification. The earliest terminology used for cervical cytology is the Papanicolaou classification, which was introduced at the end of 1940s and the early 1950s. This terminology have 5 subclasses. It starts from no abnormal cells to the presence of definite malignant cells. But each category of this classification does not have a descriptive criteria, and various laboratories use this system differently. So the interobserver variation was high. And of course, it's failed to correlate with the corresponding tissue specimens. In 1953, Regan and his colleagues introduced 3-tiered terminology, which is the same terminology used for histopathology: mild, moderate, and severe dysplasia. And in these years, dysplasia and CIS, carcinoma in situ, were described as separate diseases. Of course, again, the main problem with this classification was the poor interobserver reproducibility. In 1969, Richard introduced cervical intraepithelial neoplasia terminology in cervix pathology, intraepithelial pathologies. SIN1 corresponds to mild, SIN2 corresponds to moderate, and SIN3 corresponds to severe dysplasia. And now, with the knowledge on the pathogenesis of cervical cancer, dysplasia and carcinoma in situ was now described as a part of a spectrum. It's the part of the same spectrum of disease. This terminology also was similar between cytology and histology materials. In 1988, a workshop was held in Bethesda, and experts in cytology, histopathology, and patient management gathered together to review all these problems. They tried to find some solutions for this reporting system and the terminology used for cervical cytology. And this Bethesda system in these days first introduced and is developed to replace the various systems used to standardize terminology, which is a better correlation with the histology. It's a two-tiered terminology: low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, low cell and high cell. And into the moderate dysplasia was eliminated from the cytologic terminology. I won't go through in detail this table, but this table gives us the earliest terminology introduced in first Bethesda system, and the categories corresponds to which PAP classes. So variability in reporting with PAP smears, confusing modifications and confusing criteria, and the problematic distinction between severe dysplasia and carcinoma in situ forms a need for standardized criteria and terminology. So we can summarize the aims for a standardized reporting system as appropriate communication, clinically relevant information, consistency between laboratories, reasonable reproducibility, continuous update to reflect current pathobiology, and integration of advances in laboratory practice. So these are the three versions of the Bethesda system. This is the first workshop, which was held in 1988, was published. The first atlas was published in 1994. And then we had a revision in 2001, and the last revision was done in 2014. Shortly, the Bethesda system uses squamous intraepithelial lesion terminology. It's a two-tiered system having low and high-grade lesions. And the main important thing for this system, reporting system, is the criteria defined for adequacy. And this system requires us to include a statement of adequacy in our reports. So this last revision was based on additional experience gathered through all these years on morphology on liquid-based preparations, further insights into HPV biology, implementation of HPV vaccination, updated guidelines for cervical cancer screening, and management of abnormal cervical cytology and cancer precursors. So this table includes the categories present in this system. So first we start with the specimen type, whether it's a conventional preparation, thin prep slice, or SurePad slice. Then we come to specimen adequacy. I will go the criteria for adequacy in the following slides later on. And we give a general categorization of our findings. Negative for intraepithelial lesion or malignancy, epithelial cell abnormalities. And we finally, with these findings, give an interpretation or results of our findings. The negative for intraepithelial lesion category includes non-neoplastic findings and microorganisms. Epithelial cell abnormalities are divided into two main titles: squamous cell abnormalities and glandular cell abnormalities. So how about the specimen adequacy? We call it whether it's satisfactory or unsatisfactory. Approximately 1% of cervical smears are unsatisfactory. The main criteria used for specimen adequacy is the level of cellularity, but also there are other factors such as the presence of endocervical and transformation zone components, obscuring factors, or interfering substances. Cellularity requires well-visualized and well-preserved squamous cells. And the number of cells required for a satisfactory specimen is described for 5,000 cells for liquid-based cytology, 8,000 to 12,000 for conventional smears. But of course, with the materials taken from women after hysterectomy or postmenopausal period, or if this patient had chemo or radiation therapy, then we can lower the number of cells required for a satisfactory material, and this time they suggest to use 2,000 cells. If the level of cellularity is not adequate, first we need to overcome if there is a technical problem present and repeat the preparation for liquid-based cytology before call this material as unsatisfactory. This is an example from Bethesda book, and here we see satisfactory cytology because this is a 56-year-old woman and her status is post-total hysterectomy. So less than 50,000 cells is sufficient to call this material as satisfactory. Here is an example from our archive. This material is also satisfactory, even the cell number is low, because this patient has a history of radiation. So how can we decide how many cells we have on the slide under the microscope? First, we have to have a minimum of 10 microscopic fields at 40x, and we look through these areas along a diameter that includes the center of this circle of liquid-based preparations. And to decide how many cells present in this 40x microscopic field, we can use these tables with the properties of our IPs and objectives. We can look for the cells, how many cells is estimated in this area. And if we use SurePath and ThinPrep, the preparation diameter differs, as we know. So with the help of this table, we can decide how many cells are present on the slide. In short words, for liquid-based cytology, if less than 8 cells are present per 40x, it's an unsatisfactory material. This is an example of an unsatisfactory material, again from Bethesda book. It's a SurePath preparation, and it has less than 8 cells per 40x field. There are also some factors that may affect the number of cells present on the slides: cell clustering, atrophy, or cytolysis. This is an example from our archive, which is from an atrophic material. Due to atrophy, then the number of cells present on the slide is expected to be lower than 5,000, but still this material is adequate. So what about endocervical or transformation zone? In fact, it's not necessary for adequacy, but the presence or absence of this component should be reported in the report. At least 10 well-preserved endocervical or squamous metaplastic cells is required for both conventional and liquid-based cytology smears, and they are present in singly or in clusters. There is no association between post-negativity and lack of endocervical zone based on the literature data, but still we need to put a comment on the presence of this component, because the dysplastic lesions, the precancerous lesions in the syrinx start from the transformation zone. It's important to have sampling of this zone in order not to miss pathologic lesions. This is an example of squamous metaplastic cells from SurePath preparations from our archive. Here are the metaplastic squamous cells, and here are the endocervical cells present on the slide. Endocervical cells look like a picket here in this picture and in this picture, or they may look like honeycombing, nicely honeycombing here on this slide. These are again metaplastic cells, squamous metaplastic cells, and these projections, these cytoplasmic projections are trying as if they are try to hold their hand. So this is an example of squamous metaplastic cells. Endocervical cells sometimes be in three-dimensional groups, and they may look hyperchromatic. But when we go in high power and look at the peripheral zones of this grouping, we can detect this nicely endocervical cells present, this endocervical cell morphology present on this periphery of these groups. So cellularity, the presence of endocervical zone. Now we come to obscuring factors. Sometimes, although the number of cells are adequate, if more than 75% of squamous cells are obscured, then again, the material is unsatisfactory. If 50 to 75% of cells are obscured, then it's partially obscured. But when we call obscuring factor, we look for the nuclear detail. If the nuclei are preserved and if they are well visualized, then it's not obscured. So the key importance is the nuclear preservation. What are these obscuring factors? It may be drying artifact, it may be the presence of inflammatory exudate or excessive blood on the slide. This is an example of a material having excessive blood, and this is unsatisfactory due to this obscuring factor. But if reprocessing with glacial acetic acid, it may result in a satisfactory sample. And this is an example from Bethesda book. So how do we report this adequacy? We should report the specimen adequacy. And if the material, if the slide is unsatisfactory, the reason or reasons should also be reported. And nothing should be reported for intraepithelial lesions or neoplasia if this material is unsatisfactory, which means that we should not call it as negative for intraepithelial neoplasia. So our report will include type of specimen, of course, whether it's a conventional or liquid-based cytology. Then comes the adequacy criteria, is satisfactory or unsatisfactory. And the cervical zone, whether it's absent or present. And then the result of our interpretation, whether it's negative for intraepithelial lesion, are there any microorganisms? Is there atrophy findings, or epithelial cell abnormality? And in women aged 45 years old or older, the presence of endometrial cells should also be reported according to Bethesda criteria. Here we see under this Bethesda system that it should be given for women more than 45 years of age. And these are the examples of endometrial cells from our archive cases. So epithelial cell abnormality category includes squamous cell abnormalities and glandular cells abnormalities. The squamous cell abnormalities includes low-grade squamous intraepithelial lesions, high-grade squamous intraepithelial lesions, and if our findings are not diagnostic for low-grade lesions but are suggestive for a low-grade squamous intraepithelial lesion, then we call it as atypical squamous cells of undetermined significance, ASCUS, or if our findings are not diagnostic for high-grade squamous intraepithelial lesions, but suggestive for high-SIL, then we call it as atypical squamous cells, which we cannot exclude the presence of a high-grade lesion, and we call it as ASC-H. For glandular cells, we have atypia NOS category, we have atypia favored neoplastic category, and we have endocervical adenocarcinoma in situ category. So here is an illustration showing cervical intraepithelial neoplastic lesions from SIN1 to SIN3. And with the brush, we take these cells overlying this epithelium, and this SIN1 or coilocytosis corresponds to low SIL by cytology. SIN2 and SIN3 lesions correspond to high-grade squamous intraepithelial lesions by cytology. And the ASCUS and ASCI are the gray zone categories in this classification system. Here we see an example of a negative sample. Here we have nice coilocytes with this clear cytoplasm and high NC ratios. This is low SIL. Here is an example of ASCUS. Here we have these hyperchromatic cells which correspond to the presence of a high-grade squamous intraepithelial lesion. And on the left of this picture, we see ASC-H example, and on the right-hand side at the bottom, we see these snake cells which are corresponding to the presence of squamous cell carcinoma. Okay, so now the last revision of Bethesda system includes these categories. Of course, we have separate presentation on each category during this meeting. Before I will finish my presentation, I will just bring some literature, some papers. First, I will show you frequencies of each Bethesda category in different series. And I will also discuss inter-observer reproducibility of this reporting system. In this paper, which is published after the introduction of this last revision of TBS, and this is from practices of laboratories participating in the College of American Pathologists program. We see here that with the last revision, the reporting rates for cervical cytology metrics changed very little, and the frequencies of diagnostic categories differs in the technical methodology, whether it's a conventional preparation, TIMP preparation, or SurePath preparation. We can see these frequencies. And the atypical squamous cells ratio to squamous intraepithelial lesions are approximately 2 in these practices. With the development of FDA-approved HPV testing, according to the American Society for Colposcopy and Cervical Pathology guideline, knowing the HPV status increase the risk for SIN3 or higher lesion in diagnostic categories of Bethesda. In this, I take these tables from this paper, and here, depending on the HPV positivity, the immediate risk for SIN3 plus lesions is highly increased. This slide summarizes the frequencies from this paper. So 94% of cervical cytology are negative for intraepithelial lesion. ASCUS frequency is almost 4%, low SIL is almost 2%, and ASCI and high SIL are less than 1%. And the frequency of high-risk HPV increases when we go from low-grade lesion to high-grade lesions. This is a very recent paper. Of course, there are other papers in the literature, but because we don't have so much time to discuss all the literature data. This is from China, from an economically underdeveloped region of China. And they gathered 7 years data of their practice in cervical cytology. And they say, and their frequencies are similar to recent CAP 50th percentile rates, median rates of these categories, and their frequencies are very similar to the CAP rates. Although there are some differences, they are mainly similar to each other. You see that 4% for ASCUS and 2% for low SIL and less than 1% for high-grade lesions. And again, in this same study, with the samples having histopathologic follow-up, we see that in high-grade lesions, ASC-H or high SIL, the presence of a SIN2+ lesion in the biopsy is more than 50%, it's 82% for high SIL. And in ASCUS, we have here almost 20% of a frequency for SIN2+ lesion. When we come to inter-observer reproducibility, after the last revision of this Bethesda system, here we see that in this study, there are 518 respondents and 84 images, including all 3 types of preparations for cervical cytology. And this is an international study. And the respondents are cytotechnologists, pathologists, and so on. And here we see that the best agreement is present in negative category and low SIL category. In ASCUS, ASCI, or high-grade lesions is slightly low agreement between the observers. And we here see that the most problematic category of this Bethesda system is the glandular abnormalities. This is a different study, and this study includes only low-grade lesions. And here again, 15 experts are in this study. And there are 71 digitalized SynPrep slides. And when we do kappa statistics, we can see that in these low-grade lesions, there is a fair agreement between the observers, but the high-grade lesions are not included in this study. So the inter-observer reproducibility, in my opinion, depends on the case series in the region area of the study performed, depending on the observer's expertise level, the experience, I mean. So this changes the practices in Bethesda system reporting. So last verse, Bethesda system is a standardized and reasonably reproducible reporting system for cervical cytology. Its success encouraged the development of reporting systems for other organs such as thyroid and urinary tract and so on. It's a dynamic process, of course, in which new research may help refine criteria to improve patient care. HPV testing is important for better risk estimate. We have a presentation on HPV in this meeting also. And TBS is a successful screening tool in low economic regions where approved HPV tests cannot be reached. And I thank you all for your attention and hope to meet you in the Q&A session.
Hi, my name is Burcu Özcan. I am working at Cytopathology Department of Istanbul Education and Research Hospital. Before starting my presentation, I would like to thank the organization committee. My presentation is about non-neoplastic findings in cervical cytology. Non-neoplastic findings are classified under the negative for intraepithelial lesion or malignancy category of Bethesda system. The key thing to know is that the reason that we do pap smear as pathologists is to screen for squamous cell carcinoma of the cervix and its precursors. So the first thing we have to tell the clinician that it is negative or not. So reporting of additional non-neoplastic findings is optional, but we do it to report the changes to help clinical management and documentation of our findings. We will start with normal cellular elements, but we have lots of different categories like non-neoplastic cellular variations, reactive cellular changes, and organisms. Let's start with normal elements. As we know, the cervix is lined with non-keratinized stratified squamous epithelium, which consists of 4 main layers. These are basal cell layer, parabasal cell layer, intermediate and superficial cell layers. Cell maturation starts from the basal layer and towards the surface under hormonal stimulation. Now let's look closer to the squamous cells that make up these layers, starting from surface one by one. First one is the superficial squamous cells. They constitute the most well-differentiated group of cells. Their nuclei are pycnotic and small in size, resembling an ink dot due to their hyperchromatic appearance. The cytoplasm is relatively abundant, thin, and transparent. They have polygonal and well-defined outlines and have tendency to stain pink. The next cells are intermediate cells. They are similar to superficial cells but have slightly larger nuclei than superficial cells. Their nucleus may be elongated and may contain longitudinal grooves like this. The chromatin is finely granular and intermediate cells serve as the reference cells that you can use them to compare the size and the chromatin pattern of the other cells. Their cytoplasm is usually polygonal and may contain glycogen or keratohyalin granules like it has here. Parabasal cells are immature squamous cells derived from deep cell layers. They are commonly seen in the postmenopausal and postpartum periods. They can form small groups, but are generally distributed as single cells. Their nuclei are larger than intermediate cell nuclei, and their chromatin is fine and evenly distributed. The cytoplasmic borders are rounded, and the cytoplasm appears green and blue in color. Basal cells are the final squamous cells, but they are not typically seen in a smear unless there is a severe atrophy. They usually form syncytial-like hyperchromatic crowded groups. They are small in size and have uniform nuclei and scanty cytoplasm. Now we are moving on to the glandular elements, endocervical and endometrial cells. Endocervical cells are tall, columnar cells containing mucin in their cytoplasm. They have finely granular chromatin, and they can even look like typically as a honeycomb or picket fence-like appearance. Endometrial cells are usually observed in 3-dimensional cell clusters. Their nuclei are small and hyperchromatic, while their cytoplasm is scant. They may have degenerated appearance as they spontaneously fall into the endometrial cavity and spend some amount of time there. At the end of the menstruation, endometrial stromal cells surrounded by a layer of endometrial epithelium can be present in pap smears. And this structure is called exodus. When we see glandular cells in a smear, the following characteristics can help us to determine whether they are endocervical or endometrial. Endocervical cells are arranged in 2-dimensional layers, while endometrial cells form 3-dimensional cell clusters and aggregates. The honeycomb appearance suggests the presence of endocervical cells. Cell size may help us to endometrial cells are generally smaller than endocervical cells, and the endocervical cells have abundant cytoplasm with well-defined cell borders, while endometrial cells have scant cytoplasm with indistinct cell borders. And as I said before, endocervical cells are often well preserved, while endometrial cells commonly exhibit a degenerated appearance. By considering these characteristics, we can make an assessment to differentiate between endocervical or endometrial cells on a smear. After discussing the normal cellular elements, it's time to move on to non-neoplastic variations. This section includes three main headings: non-neoplastic changes, reactive changes occurring due to various reasons, and the presence of glandular cells after hysterectomy. Now let's start with the squamous metaplasia and keratotic changes. Changes in pH, hormonal status, inflammation, and trauma can cause the delicate endocervical epithelium to transform into a more protective squamous epithelium. This transformation is known as squamous metaplasia. But if the stimulations causing metaplasia are severe, the non-keratinizing epithelium may further transform into a keratinizing squamous epithelium, which is even more protective. And this change is known as keratosis. Squamous metaplasia starts with the reserved cell hyperplasia. Reserved cells have the ability to differentiate both into endocervical cells and squamous cells. When the epithelium is exposed to stress, they start to proliferate along the basement membrane. Then they begin to pile up, forming 2 to 5 poorly defined layers and start to show squamous features then. At first, they remain covered by a glandular epithelium, but then they lose this overlaying epithelium layer and becomes a normal squamous epithelium. Metaplastic cells exhibit different characteristics of maturation depending on the stage at which they are sampled. Immature metaplastic cells are easily recognizable, but distinguishing mature squamous metaplastic cells from other mature cells is nearly impossible. Immature squamous cells are usually found in loosely cohesive sheaths. The nucleus size is similar to that of parabasal cells. It is enlarged and nuclear to cytoplasmic ratio is increased, but doesn't exceed 50% usually. Their cytoplasm is dense and blue-green colored and have expansions which connect with others, resembling leaves or spider arms. When it comes to keratotic changes, as I mentioned before, if the stimuli that cause squamous metaplasia, such as inflammation, infection, radiation, or uterine prolapsus, are severe, the non-keratinizing cervical epithelium becomes keratinized. Keratotic changes themselves are not neoplastic. However, they can also accompany HPV-related lesions. The most commonly observed feature of keratotic changes is the presence of keratohyalin granules in the cytoplasm of superficial or intermediate cells. It is the precursor to full keratinization of the cell. This finding indicates the presence of a granular layer in the epithelium as it starts to keratinize. Keratotic changes can be divided into two main groups: typical parakeratosis and hyperkeratosis. In typical parakeratosis, the cells resemble miniature versions of superficial squamous cells. They can be observed in layers isolated cells, or like here, pearl-like structures. The cell shapes are generally polygonal and their nuclei are typically small and pyknotic. In hyperkeratosis, we observe unnucleated squames. The spaces left by the disappeared nucleus can be observed, and they are usually seen in crowded cell groups. Parakeratosis is a non-neoplastic reactive change, as I said. However, it can also be a part of a neoplastic process under the effect of HPV. The size and shape differences of the nuclei are the most important indicators reflecting a neoplastic process. In such cases, depending on the degree of atypia, a diagnosis of atypical squamous cells or squamous intraepithelial lesion is given. Hyperkeratosis, like parakeratosis, is a non-neoplastic change. However, if it's widespread, it may be covering an underlying neoplastic lesion. Therefore, in the presence of keratotic changes, it is necessary to consider the possibility of accompanying HPV infection. Now we are jumping to another normal phenomenon, tubal metaplasia. It occurs when the endocervical epithelium is replaced by fallopian tube epithelium. It is typically located in the endocervical canal or a lower uterine segment. It is observed in crowded groups with pseudostratification. As you know, normal tubal epithelium can exhibit significant nuclear changes and may look very pleomorphic. It may have a large pleomorphic nucleus appearance and would be hyperchromatic, but the presence of terminal bars and cilia is the most important clue to differentiate it from dysplasia. In cases where cilia and terminal bars cannot be identified, it may be overdiagnosed as a glandular cell atypia. Another normal element is atrophy. It is the result of the loss of hormonal stimulation. It reflects a scale ranging from severe atrophy, which is characterized by presence of basal cells, to the presence of parabasal cells. I have mentioned the characteristic of basal and parabasal cells while I was describing normal cellular elements. It is difficult to detect dysplastic changes in the presence of atrophy because observing mild degrees of atypical changes in atrophy is a normal finding. Nuclear enlargement may be present in atrophy, but nuclear contours are usually smooth and the chromatin pattern is usually fine. If there are atypical changes that raise suspicion for HPV, such as nuclear contour irregularities or coarse chromatin pattern, attention should be paid to the patient's history and the HPV status of patients. It is important to approach the diagnosis of dysplasia with caution in such cases. And in severe atrophy, densely packed hyperchromatic basal cell clusters can mimic high C. The nuclear size is small in both cases, but the nuclear membrane and chromatin irregularities resemble grazing-like appearance seen in high-grade squamous intraepithelial lesion are not observed in atrophy. The final step of non-neoplastic findings is pregnancy-related changes. Navicular cells are the typical cells seen in pregnancy. Under the effect of progesterone hormone, intermediate cells start to collect glycogen in their cytoplasm, giving the cells a boat-like appearance, and these cells called as navicular cells. Although it's a very rare situation and I have never encountered it, decidual cells and multinucleated in situ trophoblastic cells, as shown in the image, can also be observed in the pregnancy pap smears. Then we have reached a section of reactive cellular changes, and the first topic we will discuss in this group is inflammation-associated reactive and repair changes. Reactive squamous cells typically form cohesive, non-overlapping, two-dimensional cell layers. These layers exhibit a streaming pattern or a fish scale appearance. And in reactive cellular changes, minimal nuclear enlargement, B or multinucleation, wrinkled nuclear membranes may be observed. Despite these findings, the chromatin is typically fine. The distinct nucleoli is one of the key features indicating if it's a reactive change or not. Cytoplasmic borders are well defined and intracytoplasmic vacuoles may be observed. The background shows a mixture of finely granular protein precipitate, fibrin strands, inflammatory cells, and lysoid cells. Nuclear enlargement in reactive change may raise the possibility of dysplasia. However, in inflammatory change, the cells do not overlap. They are layered in two-dimensional layers and sheets, and they look like fish, the school of fish, and they have smooth nuclear contours and fine chromatin pattern. And there is an uniform cellular morphology. But in dysplasia, cells tend to overlap. They have irregular nuclear contours and coarse chromatin pattern. And there is a significant variations in size and shape of the nuclei. Lymphocytic cervicitis is a rare entity, so I will briefly mention it. It is a form of chronic cervicitis that is closely associated with chlamydia trachomatis infection. It is characterized by the presence of mature lymphoid follicles formation in the subepithelial layer of the cervix. What we see on pap smear is a polymorphic population of lymphocytes, and if it's possible, we may see tingible body macrophages like these ones. When it comes to radiation-related changes, we observe significant alternations both in nucleus and cytoplasm. Large nucleus, abundant cytoplasm, and bizarre-looking cells are typical cellular changes associated with radiation effect. Multinucleation and prominent nucleoli can be observed. Cytoplasmic vacuoles are particularly seen during the acute phase of the radiation effect. Cytoplasmic polychromasia with shades of pink and blue, like here, may be present. The chromatin is generally fine, and this is important to distinguish it from dysplasia. Nucleoli may be prominent, as I said. These changes can persist for up to 6 months or even longer following the treatment. Inflammation can accompany these changes, as seen in this image. And in this image on the right side, we observe cells with abundant cytoplasm and fine chromatin pattern, and some cells are multinucleated and they look very atypical. Reactive cellular changes associated with intrauterine contraceptive device may occur in endometrial and endocervical cells as a result of chronic irritation The cells may be present as single cells or in small groups. Nuclear enlargement and prominent nucleoli may be observed. A typical finding is the presence of large and clear vacuoles in the cell cytoplasm, which gives the appearance of a signet ring pattern. In general, the interpretation of adenocarcinoma should be made only with great caution in the presence of an intrauterine contraceptive device. If there are significant atypical changes suggestive of neoplasia, it is recommended to remove the IUD followed by a repeat cervical cytology sampling. Now, from my side, this is the most enjoyable part of this topic, organisms. The first organism in this group is a protozoa called Trichomonas vaginalis. It's a kite-shaped microorganism with an eccentric small nucleus. It is important to see this nucleus as it allows us to distinguish it from degenerated cytoplasmic fragments, which mimics this organism. The size of Trichomonas can vary considerably. In this case, there are 3 of them, and they are in different sizes. And the smallest one, little flagellum on it. We can observe Trichomonas vaginalis scattered in the background in a dispersed form, but it is also common to see multiple of them attacking to a single cell is a frequently observed finding. It is hard to detect them unless we look for them, and we don't have time to look for them on every pap smear. Therefore, it is important to pay attention to indirect findings that may suggest Trichomonas vaginalis. These findings include perinuclear halo, the presence of 3-dimensional clusters of neutrophils, these neutrophil balls, widespread eosinophilia of superficial cells, and the presence of leptotrix accompanying the Trichomonas vaginalis. Leptotrix is a gram-positive anaerobe rod, which is longer than lactobacilli. On the left image, a colony of Trichomonas vaginalis is observed on the superficial cells, and there is another lonely one here. And on the right image, a cluster of neutrophils and Trichomonas at the background are seen. Actually, the perinuclear halo is not a specific finding for Trichomonas, but it often comes with it. It differs from halo seen in HPV-related changes. It is a space associated with the contracted nucleus due to the alcohol-based fixation. Therefore, it is smaller and has indistinct borders compared to HPV coilocytes. Additionally, the presence of atypical nuclei is not observed in Trichomonas vaginalis. The next organism is Candida. Different types of Candida species can be observed in a smear, but the most commonly encountered one is Candida albicans. It is not necessary to determine the specific subtype since the treatment remains the same, and the initiation of treatment usually requires the presence of clinical symptoms. And Candida infections typically have a self-limiting nature. Pseudohyphae and spores can be observed on the smear. The pink-blue colored pseudohyph structures appear intertwined with squamous cell clusters. Sometimes the cells can appear arranged along these hypha-like structures resembling a shish kebab appearance. This feature is readily appreciated at low power even when the pseudo-HIV fuzz are not prominent. It is common to observe cells with a depleted appearing cytoplasm or a crumpled paper-like appearance. Here we can also see other examples of Candida HIPA and spores in different images. Bacterial vaginosis is another commonly encountered type of colonization. It is referred to as vaginosis rather than vaginitis because it lacks inflammation findings. This condition is believed to occur due to the absence of interleukin-8 stimulation. Although Gardnerella vaginalis is the most frequently observed organism in bacterial vaginosis, it is not caused by a single organism. Indeed, it's a polymicrobial syndrome. Gardnerella vaginalis is normally present in the vaginal flora, but becomes dominant when there is a decrease in lactobacilli population. Clue cell is the squamous epithelial cell which is covered with Fucobacilli and is the typical cell of bacterial vaginosis. Another bacterium encountered in smears is actinomyces. Actinomyces can be found in normal flora of mouth and colon. It is a gram-positive filamentous bacterium. Actinomyces israeli is the most thin subtype. It is observed in approximately 25% of individuals using intrauterine contraceptive devices. If it's asymptomatic, there is no need to remove the device. They appear as cotton balls or woolly bodies. They are often seen mixed with other bacterial colonies. Spider-like eggs, like here, are typical for actinomyces. The next organism is herpes simplex virus. It exhibits typical morphological features. These can be summarized as the 3 M features. What are they? They are multinucleation, margination of chromatin, and molding of nucleus. The nucleus shows a ground glass appearance caused by viral particles and may have intranuclear inclusions called Cowdery bodies. In the differential diagnosis, multinucleated histiocytes and endocervical cells forming syncytial groups are considered. However, the ground glass appearance and nuclear molding and inclusions are not observed in these cells. The last organism is cytomegalovirus. It's commonly seen in immune-compromised individuals and mostly affects endocervical and glandular cells. It causes cellular and nuclear enlargement and a large eosinophilic intranuclear inclusion with a prominent halo around it and looks like the owl's eye. Small cytoplasmic and basophilic inclusions may be seen, but it is very rare.
Hello, dear colleagues and attendees. I am Şanay Erdoğan Durmuş. I am a pathologist and cytopathologist at Professor Dr. Cemil Taşçıoğlu City Hospital in Istanbul. Today my topics are atypical squamous cells, undeterminate significance, and low-grade squamous intraepithelial lesion. Atypical squamous cells, undeterminate significance, we called ASCUS, constitutes 90% of the atypical squamous cell category, and high-risk HPV positive in 50.06% of these cases. ASCOS reversed refers to changes that are suggestive of low-grade SIL, not in quantity or quality to call low-grade cell, but we see more pronounced atypia than reactive atypia. In picture, we see an intermediate cell, and there is an atypical cell with nuclear enlargement and mild hyperchromatic. Nuclei are approximately 2.5 to 3 times the area of the nucleus of a normal intermediate squamous cell, or twice the size of a squamous metaplastic cell nucleus, and slightly increased nucleus-cytoplasmic ratio we can see. We can see also minimal nuclear hyperchromasia, minimal irregularity in chromatin distribution, and minimal irregularity in nuclear shape. In picture, we saw a small hollow, irregular nuclear shape, and minimal irregularity in chromatin distribution, and then enlargement we see. This is an example of liquid-based cytology preparation, TIMPREP, binucleated cells with nuclear enlargement. We see molding, mild chromatin granularity, orangeopilic cytoplasm. The biopsy result was low-grade SIL for this case. This is an example of conventional preparation. Cells with enlarged and hyperchromatic nuclei, mild hyperchromasia. Some are multinucleated. This is an example of conventional preparation. Again, metaplastic cells with nuclear enlargement we can see, and binucleated cells with clear perinuclear halo. This is an example from routine screening in a perimenopausal woman, liquid-based cytology preparation, SurePET, several atypic cells with nuclei enlargement, slight hyperchromasia, binucleation and perinuclear cytoplasmic clearing are seen. Repeat cervical cytology was negative for this case. Liquid-based cytology preparation example, TIMPREP. There is an atypical cell, intermediate squamous cell. Background is inflammatory. The nucleus is enlarged and with irregular nuclear contours. This is again a liquid-based cytology preparation, TIMPREP, atypical cell with enlarged nuclei we can see, with irregular nuclear membrane, and we see binucleation in this cell. The biopsy result was low-grade SIL for this case. Atypical parakeratosis should categorize in ASCOS. We see cohesive sheet of spindled keratotic cells and nuclear enlargement in atypical parakeratosis, hyperchromasia, orangeopilic cytoplasms. And this is another example for atypical parakeratosis, dense orangeopilic cytoplasm, hyperchromasia, 3D group, irregularity and nuclear shape. This is sometimes very challenging in some cases. And incomplete choliocytosis will categorize in ASCOS, poorly defined cytoplasmic halos or cytoplasmic vacuoles resembling choliocytes, but nuclear changes are minimal or absent. Atypical repair, again, can be very challenging in some cases. We can see cellular overlapping, anusonucleosis, discohesion, and loss of nuclear polarity. Atypical repair should categorize in ASCOS. Atypia in postmenopausal women and atrophy, we see mild nuclear enlargement. But we don't see significant hyperchromasia, nuclear irregularity, and there is no prior history of cases or no prior positive HPV. Reactive changes in atrophy can be challenging in some cases. This is a reactive atrophic changes in a case. we see this. There are preparation effects according to preparation type or fixations. In conventional preparation, cells may appear larger and flatter due to the smearing and or air drying artifact. In this picture, there are mild hyperchromatic cells with nuclear and mild nuclear enlargement and multinucleation. The biopsy result was CIN1 for this case. And in liquid-based preparations, cell may appear more smaller, higher nucleocytoplasmic ratios we can see, and two-dimensional views due to the fixation. And this is one of these examples from liquid-based preparations. We saw perinuclear clearing, mild perinuclear clearing, mild enlargement. This case, biopsy result was low-grade SIL, low-grade SIL for this case. Sorry. In some cases, we should prefer negative category, especially if we think the changes are reactive. In this example, there's inflammatory background, an intermediate squamous cell with enlarged nuclei with normal chromatin. This is very important. This case should category in negative category instead of ascus. Sorry. And this is again an inflammatory background example. This is another example for this situation. There are metaplastic cells with slightly enlarged nuclei and again an inflammatory background. This is reactive changes. These are reactive changes, and we should prefer negative category instead of ascus. In here, metaplastic cells with enlarged and clear nuclei we can see in picture. And there is again an inflammatory background. This is a typical repair change, and typical repair change should category at negative category instead of ascus category. HPV positive ascus estimated 5-year CIN3 risk 4.5%. HPV negative ascus estimated 5-year CIN3 risk is 0.40%. 2019 ASCCP guideline provide an algorithm based on CIN3 risk greater than 4 or not. HPV negative ascus cases with no prior history of epithelial cell abnormalities, estimated CIN3 risk is smaller than 4, and 3-year follow-up is recommended for these cases. HPV positive ascus cases CIN3 risk was bigger than 4, and colposcopy recommended for these cases. This is another table for HPV positive ascus cases. Recommendation is colposcopy. If colposcopic biopsy result is better than CIN2, 1-year follow-up is recommended. In this first follow-up, if HPV positive ascus found again, 1-year follow-up is recommended. When HPV negative and cytology is negative, 3-year follow-up is recommended. But in second follow-up, HPV positive and cytology is ascus, again, colposcopy is recommended. In summary, HPV negative ASCOs should return for co-testing at 3 years. HPV positive ASCOs should be preferred for colposcopy. If colposcopic biopsy results is better than CIN2, co-testing at 12 months is recommended. If all tests are negative at that time, routine screening is recommended. For women with ASCO cytology and no HPV result, repeat cytology at 1 year is acceptable. If the result is ASCO or worse, colposcopy is recommended. If the result is negative, return to cytology testing at 3-year intervals is recommended. In 2019 ASCCP guideline, patients older than 65 years, if undergo HPV testing, co-testing, or cytology, and if we find ASCOs, management are the same, the patient's age 25 to 65 years old. If patients younger than 25 years, if we find ASCOs or low-grade SIL, it is same recommendation. Same repeat cytology is recommended at 1 year. If we find high-grade cytology, ASC-H, high-grade SIL, or atypical glandular cells, colposcopy is recommended. If we find negative or ASCOs or low-grade SIL, repeat cytology at 1 year is recommended, and it's again negative, routine screening is recommended, but it is ASCOs or worse, colposcopy is recommended. This is a picture from Eminönü, Galata Tower. My second topic, low-grade squamous intraepithelial lesion. Squamous cells chains related to HPV infection include microdysplasia and CIA1. Usually associated with mature intermediate squamous cells or with superficial squamous cell type cytoplasm. Nuclei are generally hyperchromatic, rarely normochromatic. Anisonucleosis, we see chromatin is uniformly distributed and ranges from coarse granular, smudgy, or densely opaque. Nuclear enlargement more than 3 times the area of a normal intermediate nuclei, and it results in a low but slightly increased nucleocytoplasmic ratio. We see in picture a intermediate squamous cell, and we saw 2 atypical cells. One of them was have a nuclear enlargement more than 3 times of intermediate squamous cell nucleus. And it should diagnose as low-grade SIL. And the other one is 2.5 to 3 times nuclear enlargement of an intermediate squamous cell nucleus, and it may be diagnosed as ASCOs if it is alone. In low-grade SIL, we see binucleation and multinucleation. Nuclear membranes can be smooth or very irregular. Nucleoli are generally absent or inconspicuous if present. Choriocytosis or perinuclear cavitation, it's a characteristic feature for viral cytopathic effect, but it's not essential for low-grade SIL. We see sharply demarked clear perinuclear region and a peripheral rim of a densely stained cytoplasm. Cell may show increased keratinization with dense eosinophilic cytoplasm with little or no evidence of choriocytosis. Cells with choriocytosis or dense orangophilia must also show nuclear abnormalities to be diagnostic of low-grade SIL. And this is a conventional preparation example, eosinophilic and basophilic choriocytosis. We see in picture associated with parakeratosis in here and binucleation. Liquid-based preparation of low-grade SIL. The feature is not much different from conventional preparation. Cell size may be more smaller and hyperchromasia may be less. And this is example of liquid-based cytology preparation, SurePet. We see nuclear cavitation, nuclear enlargements, mild hyperchromasia, and binucleation here. This is an example, again, liquid-based cytology, again, TIM prep, this time perinuclear cavitation, we see, binucleation, nuclear enlargement, mild, and hyperchromasia. This is again a TIM prep liquid-based cytology example. Enlarged nuclei, variable chromatin, variable nuclear membranes, perinuclear cavitation. This is example liquid-based cytology SurePet preparation, binucleation, enlarged nuclei, and variable chromatin, sharply demarked perinuclear cavitation. And this is again a liquid-based cytology example, TIM prep. We saw binucleation, nuclear enlargement, nuclear, very hyperchromatic cells, enlarged nuclei, nuclear size are more than 3 times of normal intermediate nucleus. This is again a TIM prep preparation. We saw intermediate cell nucleus and atypic nucleus, enlarged nuclear size are 3 times, more than 3 times of the nuclear intermediate nucleus. Again, liquid-based cytology example, hyperchromatic, enlarged nuclei, and mild perinuclear clearing. This is again TIM prep liquid-based cytology preparation, increased cell size, smudge, chromatin, and hyperchromasia, multinucleation. We see when well-defined cytoplasms and category diagnosed as low-grade SIL. There are problematic patterns in low-grade SIL. The assessment of low-grade SIL should be based on strict criteria to prevent unnecessary follow-up. Several pitfalls and gray areas should be kept in mind. One of these problematic issues, keratinized squamous cells, parakeratosis alone is not an HPV-associated condition, may be present as a background pattern in HPV-associated lesions. Keratinized squamous cells with nuclear abnormalities with low nucleocytoplasmic ratios should be categorized as ascus or worse. I talked about it at atypical parakeratosis in ascus section. This category was based on the degree of nuclear abnormality. Sometimes it can be categorized as low-grade SIL. Borderline changes are problematic issue again. Specimen with borderline nuclear changes that fall below a definitive low-grade SIL diagnosis may be categorized as ascus. In this picture, we saw atypical cells, with nuclear enlargement, mild hyperchromasia with white hyperchromasia, but not irregular. There is no irregular contour. Nucleus contour is smooth. Should be maybe categorized as ascus. There are mimickers of low-grade SIL. Trichomonas infection make pseudochoriocytosis and can be a mimicker of low-grade SIL. These are Trichomonas microorganisms at the background, and we saw a inflammatory small halo in squamous cell. The borders are not sharp and nucleus is normal. This is again a Trichomonas infection. These are Trichomonas microorganisms. And there's a pseudo-halo, pseudochoriocyte in a squamous cell, showing with arrow, black arrow. Another pseudochoriocytosis feature is cytoplasmic vacuolation due to the glycogen. In in this vocalization, we see broad but not sharp borders, and nucleus is normal. This is another example for vocalization of glycogen. We see a yellowish color for these cases, and nucleus are normal. Nuclei are normal. Herpetic cytopathic effect can mimic sometimes low-grade SIL. Classical herpes cytopathic effect does not create a problem in differential diagnosis. However, diagnostic nuclear features may not have formed in early herpes infection. In early herpes infection, cases may be confused with loci, nuclear enlargement, degenerative chromatin, which may be hyperchromatic, can cause low-grade SIL diagnosis. But we don't see choliocytosis in herpes infection, and other features of herpes should be searched, such as multinucleation, molding, margination, and inclusion. Sometimes herpetic changes can also mimic high-grade SIL. Radiation changes can mimic low-grade SIL. Large nuclei with low nucleus-cytoplasmic ratio, vacuolated cytoplasms, but we don't see perinuclear clearing or peripheral condensation presence in a typical choliocyte. HPV negative low-grade SIL estimated 5-year risk, 5-year CIN3 risk is 1.1%. HPV positive low-grade SIL estimated 5-year CIN3 risk is 4.3%. It is very similar HPV positive ASCUS. In the data from the ASCUS low-grade SIL triage study, ALTC study, we all know about it. High-risk HPV types were detected in 85% of low-grade SIL cases. First, I want to talk about 2012 ASCCP guidelines, recommendations for low-grade SIL. After, I will try to explain 2019 ASCCP guideline recommendations for low-grade SIL. In 2012 ASCCP guidelines, the recommendations are these. Women under the age of 25 with a cytologic interpretation of low-grade SIL, we follow up with cytology at 12 months. Women 25 years and older can be co-tested in 3 years if they are HPV negative. Women 25 years and older, colposcopic examination is recommended if HPV positive. And women of unknown HPV status should have repeat cytology in 12 months. But in 2019 ASCCP guidelines, the recommendation for screening is with HPV or HPV plus cytology co-test. Surveillance with cytology alone is acceptable only if testing with HPV or co-testing is not feasible. All positive primary HPV screening tests, regardless of genotype, should have additional reflex triage testing performed the same laboratory specimen, reflex cytology. I showed this table before, and I told that HPV positive low-grade SIL CIN3 risk is very similar to HPV positive ASCUS CIN3 risk. And HPV positive low-grade SIL risk is bigger than 4, and a colposcopy is recommended. In HPV negative low-grade SIL, CIN3 risk, according to CIN3 risk, 1-year follow-up is recommended according to the risk-based algorithm. And the older patients and younger patients, the recommendations for low-grade SIL is the same as ASCUS. If older patients from 65 years undergo HPV testing, co-testing, or cytology. If we find low-grade SIL, management are same. The patients we aged 25 to 65 years is recommended. And in young patients than 25 years, if we find ASCUS or low-grade SIL, repeat cytology at 1 year. And if we find high-grade cytology results, ASC age, high-grade SIL, and atypical glandular cells, colposcopy is recommended. If we find negative ASCUS or low-grade SIL, again, repeat cytology at 1 year is recommended. And it is negative, routine screening is recommended. But it is worse, ASCUS or worse, colposcopy is recommended. Take-home messages for ASCUS. ASCUS refers to changes that are suggestive of low-grade SIL, attention to atypical parakeratosis, atypical repair, and postmenopausal atypia. These are can be very challenging in some cases. Low-grade SIL, nuclear enlargement and coarse granular chromatin is important. Characteristics of the choriocyte is important. And concomitant nuclear atypy is very important and should be there for the diagnosis of low-grade SIL. And attention choriocyte mimickers, it can be challenging, especially trichomonas infection. And in management, they have similar CIN3 risk, HPV positive ASCUS and HPV positive low-C, and colposcopy is recommended for these cases. And HPV negative ASCUS, 3-year follow-up is recommended, and HPV negative low-grade SIL, 1-year follow-up is recommended. These are my references. I took some help and some pictures from these atlas. They are very helpful for residency, especially. I want to thank Dr. Burcu Özcan, my friend, my colleague, for her support and some pictures. And I want to talk our mentor at Cytopathology Fellowship Program at Cerrahpaşa, Professor Nesrin Uygun. She's a great mentor, great cytopathologist, and we learn from her so many things. Thank you. Thank you for all attendees for your attention.
Dear colleagues, firstly, I want to thank the organizing committee for this organization, and also to you for joining us. In my presentation, I will start with how to diagnose squamous and epithelial lesions. I know this was also the subject of the previous lectures, but I will briefly give information about how to diagnose squamous and epithelial lesions firstly. Then after this, I will talk about high-grade squamous and epithelial lesions. Atypical squamous cells cannot exclude high-grade squamous and epithelial lesions will follow this. And invasive squamous cell carcinoma will be the last subject. When we evaluate a pap test, the first step is whether or not to decide the cells are atypical. When we decide as the cells are atypical, in the second step, we need to grade this dysplasia. Yes, that's how we decide whether a cell is atypical or not. Let's see this firstly. As in other cytology specimens, nucleus is the most important part for us. We need to compare the nucleus to an intermediate cell nucleus for the size, outline, chromatin texture, and staining. Let's look at each of them with slides, with different cases. In the atypical cells, the nuclei is about 3 to 6 times of an intermediate cell nucleus. In the right side, we see 3 different cases, and some of them have large-sized nuclei. The arrows showing us the normal intermediate cell nucleus, and we will compare the size of these atypical cells with the intermediate cells. And when we look, we see that they are about 3 to 5 times fold of a normal intermediate cell. So we can decide that there's an increase in size of these atypical cell nucleus. But we need to remember that in some high-grade squamous intraepithelial cell lesions, the nuclei may be as small as a normal intermediate cell nucleus, as it is shown in this picture. Also, there's an intermediate cell at the bottom of this picture at the left side, and the atypical cells are present in the lower right side. We can compare the size of these ones, and some of them have similar size, but some of them are larger than an intermediate cell nucleus. Contour outline of a nucleus is also important. Nuclear contour irregularities are a clue for an atypia in a cell. And here, the circle showing us nuclear outline irregularities and the arrows showing us groove formation in these cells. But the grooves can also be seen in normal, non-atypical cells. Comparing to an intermediate cell nucleus, the chromatin texture is also different. A coarse chromatin pattern, speckled chromatin pattern is seen in atypical cells. Also, staining of the nucleus of the atypical cells will show hyperchromasia. But we need to remember that in some cases, rarely, the nucleus may be normochromatic or even hypochromatic. And in the right side, we see such a case with an overlapping of hypochromatic nuclei with irregular nuclear membranes. This is an example for an high-grade squamous intraepithelial lesion. With all these features, we decide that this cell is atypical, or the group of cells are atypical. Then now it's time to grade the dysplasia in these cells. Nucleus to cytoplasmic ratio is a measure of maturity of a cell, and higher NC ratios are seen in more advanced dysplasias. In higher grade lesions are composed of parabasal size, metaplastic size cells that usually stain blue-green. We can here compare the sizes of the cells for the low-grade lesions and high-grade lesions. In low-grade lesions, the cells are bigger. They have a similar size with an intermediate cell. In the high-grade lesions, the sizes of the atypical cells are smaller, resembling a parabasal cell or a metaplastic cell. And so smaller cells indicate, with atypia, of course, higher grade lesions. Comparing the low-grade lesions, the high-grade squamous intraepithelial cells are composed of smaller cells. We have seen this in the previous slides, and all of the nuclear features that we describe for atypia are more prominent. There's a more irregular nuclear membrane, coarser chromatin pattern, scantier cytoplasm, and higher NC ratio. And also we need to remember that nucleoli is not a feature for high-grade squamous intraepithelial lesions or the lesions that are restricted to epithelia. So in most of the cases, nucleoli are inconspicuous. Prominent nucleoli indicates us invasive cancers, but also here we need to remember that some of the high-grade squamous intraepithelial lesions can involve the endocervical glands, and during endocervical gland involvement, prominent nucleoli can be seen in such cases with high-grade squamous intraepithelial lesions. Let's look at all of the nuclear features again with different examples. Here you see a low-grade squamous intraepithelial lesion and a high-grade squamous intraepithelial lesion. And in the high-grade squamous intraepithelial lesion, nuclear outlines are more irregular, as it is shown here. There's a coarser chromatin pattern comparing to low-grade lesions in high-grade squamous intraepithelial lesions. And maybe the most important feature for grading a dysplasia in atypical cells is the presence of scantier cytoplasm and presence of higher NC ratio in these cells. Comparing to low-grade lesions, there's a scantier cytoplasm and higher NC ratio in high-grade lesions. And size of these cells are smaller than low-grade squamous intraepithelial lesions. In high-grade squamous intraepithelial lesions, the atypical cells can be seen as single cells, or they may form three-dimensional syncytial-like aggregates, especially in conventional smears. In syncytial-like aggregates, cytoplasmic borders between the cells cannot be visualized, and there is a loss of nuclear polarity within the groups. This is an important feature to describe a group as syncytial-like aggregate. Also, hyperchromatic crowded groups can be present, especially this is a feature for the liquid-based preparations, and in some cases, naked abnormal nuclei may be present. And here we see examples for these cases: isolated single cells, which have small size with an increased NC ratio, scantier cytoplasm, and hyperchromasia is present in the left side. In the center, we see a hyperchromatic crowded group in a liquid-based preparation. And in the right side, we see a syncytial aggregate in a conventional smear. Sometimes in high-grade squamous intraepithelial lesions, small basaloid immature dysplastic cells can closely resemble histiocyte. These cells usually present in a streaming pattern in a mucus, and definite assessment is possible in these cases in higher magnification. On higher magnification, atypical cells will show the squamous cell nature. These cells will have polygonal, these cells are in polygonal in shape, and they have a dense cytoplasm. In histiocytes, there's an excentrically located oval to round nuclei, and the foamy cytoplasm is present. These are the features that favor histiocytes. Beside close view of such cells, also in the remaining slide, searching the slide for low-grade dysplastic cells can help to differentiate atypical cells from histiocytes. We know that in usually high-grade dysplasia accompanied by low-grade dysplasia, as it is in this case. And I will show you the histologic outcome of this case in the next slide. And a biopsy of this case showed a high-grade squamous intraepithelial lesion. You see here this. And in some high-grade squamous intraepithelial lesions, the cytoplasm of atypical cells are mature and densely keratinized. These belong to keratinized high-grade squamous intraepithelial lesions. Rarely, some high-grade squamous intraepithelial lesions may show severe dysplastic cells, which are seen as tiny little cells with subtle cytologic abnormalities. This is an uncommon cytologic pattern. In these cases, the dysplastic cells resemble reserve cells. They are small in size. In most of these cases, the chromatin is hyperchromatic. have an hyperchromatic appearance, but evenly distributed chromatin pattern with variable chromocenter formation can also present in such cases. Nucleoli are inconspicuous in such cases. And these cells, these small size cells, may be present singly or in a syncytial aggregate, and the nuclei can be seen as round in appearance, or sometimes segmental shapes can be present. Presence of mitotic activity in such cases is helping us to diagnosing atypia in such cases. In a pap smear, when the cells resemble immature squamous cells, but the nuclei are slightly enlarged, frequently hyperchromatic, and have regular outlines, then we will call these cases as atypical squamous cells cannot exclude hysil ascage. In ascage cases, the cells usually occur singly or in small groups, which are composed of less than 10 cells. You here see to such cases when these atypical cells indicating the nuclear features of these atypical cells indicating a high-grade lesion, but they are sparse, you will prefer to diagnose these cases as ascage. And follow-up of these two cases is shown in the left side, a squamous cell carcinoma, and in the right side, a high-grade squamous intraepithelial lesion was found during follow-up. Here we see two slides. The cells are the size of metaplastic cells, and there's a hyperchromasia in these cells. And also in the left side, and slightly the nuclear irregularity in the outline is present. But when the smear is limited to a few cells that have these features, when the atypical cells are sparse, the most appropriate category for such cases will be ascage. Here, another two cases are shown. In the left side, the circles are showing us small size cells with a high NC ratio. The nuclei of these three cells indicating us a high-grade lesion with hyperchromasia with increased NC ratio. Also, there's an atypical cells which have larger size, and this is shown with an arrow. So a low-grade lesion and high-grade lesion is present together here. But if the cells that have atypical features are limited to only 4 to 5 cells, less than 10 cells, then atypical cells cannot exclude a hysil will be appropriate for these cases. And in the right side, another case is present. In the bottom right side, we see strip nuclei. These strip nuclei have enlarged appearance with hyperchromasia, and irregular chromatin pattern is also present. These abnormal, large, hyperchromatic strip nuclei should elicit a search for intact high-grade squamous intraepithelial lesion cells. And if we cannot find anymore, then we can diagnose such cases as ascage. Also, you need to remember that such abnormal strip nuclei may be present in atrophic smears, and also shed endometrial cells may have similar appearances. Some high-grade lesions have subtle nuclear abnormalities. Also, overlapping nuclei are difficult to interpret in liquid-based preparations. In such cases, focusing up and down at high power may help to differentiate such cells. And let's focus up and down in such a case. What happens, we will see And with then focusing up and down, we can evaluate such cells better. And a small group of cells with hyperchromasia, small size cells are present here, especially the one that is circled, have a high NC ratio with hyperchromasia and nuclear contour irregularity. If you see such a case, after focusing up and down, you can search the remaining slide for a resinoid nuclei and speckled chromatin pattern. This may help you to diagnose such cases. But if you cannot find better preserved cells, then you can categorize these cases as ASCH. In a pap smear, hyperchromatic crowded cell groups should be examined with care. Center of such clusters is often difficult to evaluate due to dense and dark nature of the center. Close examination of the periphery of the clusters will usually allow for better evaluation of the cells. And with a close examination of the periphery of this group, we see that these cells have enlarged nuclei with hyperchromasia. Slight nuclear contour irregularities are also present with an increased NC ratio, which indicate us and higher grade lesions. Also, searching the slide for single dysplastic cells in the background may help to differentiate these cases. And in this case, we have found a few cells with hyperchromatic nuclei, coarse chromatin pattern. But the naked cells, these are the naked nuclei without the cytoplasm. With these hyperchromatic product groups and with these strip nuclei, you can diagnose such cases as high-grade squamous intraepithelial lesion. And follow-up of this case showed an high-grade squamous intraepithelial lesion. Hyperchromatic crowded groups are not only the feature of an high-grade squamous intraepithelial lesion. Besides this dysplastic process, some benign entities can also be seen with hyperchromatic crowded groups, and these are listed here. Immature squamous metaplasia, atrophy, benign endocervical cells, and endometrial cells may be seen as hyperchromatic crowded cell groups. Metaplastic cells have mild nuclear enlargement with mild membrane irregularity with an uneven chromatin distribution. But sometimes hyperchromasia and the small size of these cells with increased NC ratio, which resembles a high-grade lesion, make confusion, make misdiagnosis of such cells. Here we see a case with small size atypical cells. In these three cells, the cells have increased NC ratio with dense cytoplasm, which indicates squamous nature in these cells. But the nuclear outlines are smooth. A mild hyperchromasia is also present. It is hard to decide whether these cells are metaplastic or belong to a high-grade lesion. So in such a situation, we can call these cases as ASCH. And follow-up of this case showed immature squamous metaplasia. Another case is present here, which belongs to a young woman. These cells have increased NC ratio with irregular nuclear outlines with hyperchromasia. And again, you can, in some cases, you cannot decide whether these cells are metaplastic cells or an high-grade lesion is present. So you can call these cases as ASCH. And follow-up of this case showed an high-grade squamous intraepithelial lesion. In atrophic smears, the cells have small size with high NC ratio. These are the parabasal cells. With these features, the presence of nuclear hyperchromasia and smudging associated with degeneration may raise a difficulty in interpretation of these cells. In benign atrophy, there will be no nuclear overlapping. Blood may be present in the background, but there will be no necrosis. In dysplastic lesions, there will be nuclear overlapping in a single plane, and mostly these atrophic cells may be seen as syncytial aggregates. Beside the blood, frank cellular necrosis will be seen in the background. And now we see another case from an old woman. There's a hyperchromatic crowded groups in the background with a proteinous material, which resemble necrosis, but a proteinous material can be seen deep atrophic smears, and high-risk HPV testing is negative in this case. But beside these hyperchromatic groups, which are seen in the previous slides, some of the groups have more hyperchromatic appearance, and also an attached proteinous material to a group is present here, which resembles and clinging diathesis in the liquid-based preparation. And on higher power, under higher power, the identification of the nuclear details are insufficient, but we can only say these are small size cells with hyperchromasia with increased NC ratio. From the remaining vial, we prepared cell block from this case and an atrophic epithelium with low proliferation index, which is restricted to the basal layer with a Ki67 staining were demonstrated, and we diagnosed this case as atrophy. But if we do not have a chance to make a cell block and to see the high-risk HPV, whether it's negative or positive, then we can call such cases as ASCH. Benign endocervical cells and endometrial cells also can be problematic. They can form hyperchromatic crowded groups too. Groups of the endocervical cells, when weaved on end, can form hyperchromatic crowded groups, and some degenerated endocervical cell and phase with scan cytoplasm also can mimic ASCH. We know that in benign endocervical cells, there is a regular nuclear membrane, evenly distributed chromatin pattern, and honeycomb structure or mucus cap, when focusing up and down, can be shown above the nuclear plane. These are the features to help to distinguish this mimic. And dense cytoplasm, polygonal cell shape, fragments with flattening of cells at the edges or sharp linear edges favor squamous over glandular differentiation. And a smear with a low cellularity is present here, and encircled ones will be shown on high power. These are hyperchromatic crowded groups. On high power, we can recognize that one of them is an endocervical cell group with a honeycomb pattern, but the other small group cannot be diagnosed as an endocervical group easily. These cells have small nuclei, but with a coarser chromatin pattern and increased NC ratio. Slight hyperchromasia is also present, so these features are suspectable for a high-grade squamous intraepithelial lesion. Also here, other groups are present in the remaining slides. which resembles the small size group. In these cells, high NC ratio with hyperchromasia is present, but in the left side, the chromatin texture is not abnormal, evenly distributed, and the nuclear outlines are well preserved. So the left side may belong to an endocervical cell group, but in the right side, again, a high-grade lesion can be suspected. In the remaining slides, we found another group, which is also seen as an hyperchromatic crowded group. And at the periphery, we can identify the nuclear details in this group. And we see that a coarse chromatin pattern with increased NC ratio and hyperchromasia indicate a high-grade squamous intraepithelial lesion in this case. Also, high-risk HPV31 is positive in this case, and we diagnose this case as high-grade squamous intraepithelial lesion. Also, we prepared a cell block from this case, from the remaining fluid in the vial, and we also show the high-grade squamous intraepithelial lesion in the cell block sections. Endometrial cells also can form hyperchromatic crowded groups, which are formed by the small size cells with a hyperchromatic nuclei, increased NC ratio. All of these features can mimic a high-grade squamous intraepithelial cell lesion. Two different cases are shown here. Both of them shows us hyperchromatic crowded groups with small size, increased NC ratio. And both of these groups are can be suspected for a high-grade lesion or for an presence of endometrial cells. And follow-up of these cases are shown here. The left side, in the follow-up of the left side, show a negative for intraepithelial lesion and malignancy. These are belonging to an endometrial cell group. And in the right side, follow-up of this case showed a high-grade squamous intraepithelial lesion with endocervical glandular involvement. Small round nucleus with smooth nuclear membranes, nuclear opacity and pycnosis, presence of apoptotic bodies within the groups are favoring benign endometrial cells. Also, comparison to more classical clusters of endometrial cells from the same slide is useful in differentiation. The typical endometrial cell groups will have organized architectural configurations. Also, presence of associated endometrial stromal cells in the center are the clues for the presence of endometrial cells. In this picture, three-dimensional cell group is present. The dark side of which is present in the center, indicating us the stromal cells, and epithelial cells are covering the stromal cells. A double contour is present in this case. In a hyperchromatic crowded group, if the cells are abnormal but with glandular features, in the differential diagnosis, endocervical adenocarcinoma in situ or invasive endocervical and endometrial adenocarcinomas should be considered. Flattening at the edges of cell clusters, whirling of cells in the center, lack of glandular architectural features favor high-grade squamous intraepithelial lesion over a glandular abnormality. Feathering, rosettes, pseudostratified strips favor glandular abnormality. In the left side, in both of these pictures, we see hyperchromatic crowded groups. In the left side, a whirling is apparent. In the center, the cells have a high NC ratio with hyperchromasia. This whirling in the center and flattening at the edges of the groups suggests a high-grade squamous intraepithelial lesion over a glandular abnormality. And in the right side, crowding is present in the group, but featuring at the edges Besides the lacking columnar appearance of the cells, favor a glandular abnormality. And follow-up of these cases is shown in the left side, show and high-grade squamous intraepithelial lesion with endocervical glandular involvement, and in the right side, follow-up show and adenocarcinoma in situ. Some of the high-grade squamous intraepithelial lesions may show features which are suspicious for invasion. Highly pleomorphic high-grade squamous intraepithelial cells with keratinized cytoplasm without a background of tumor diathesis may give rise for this suspicion, or the slide may contain features suggesting tumor diathesis without overly malignant cells. These two situations may be suspicious for invasion. Squamous cell carcinomas. In atypical cells, nuclear features of high-grade squamous intraepithelial lesion is present. Beside these features, prominent nucleoli, especially as a macronucleoli, is seen. But most importantly, tumor diathesis, which is formed by necrotic debris and broken down blood elements, are seen. Comparing to high-grade squamous intraepithelial lesion, there's a marked variation in cellular size and shape in the nuclei of the atypical cells, and nuclei very markedly in area. Two classical examples of squamous cell carcinoma are shown here. There's a prominent variation in the size of the cells and the nuclei with prominent nucleoli in the atypical cells. We said that most important feature diagnosing invasion in a pap smear is the presence of tumor diathesis. In liquid-based preparations, diathesis materials tend to aggregate into balls or clings to the surface of the cellular material. This is called as clinging diathesis, and it's shown in the right side. In the right side picture, keratinized atypical cells are present, and the clinging tumor diathesis is also seen. The follow-up of this case showed an invasive squamous cell carcinoma. In the left side, we see a group of cells which show marked atypia with prominent nucleoli, and also tumor diathesis is present in the background. So all of these features can easily make us diagnose squamous cell carcinoma. But in some cases, we need to remember that tumor diathesis is widely present in the background, and it may be the prominent feature of the pap test. Only limited abnormal cells, sparse, scant abnormal cells can be present in such cases, and it will be hard to diagnose squamous cell carcinoma in such pap smears. Keratinizing form of the squamous cell carcinomas will show caudate or spindle-shaped cells with dense orange-oblique cytoplasms. Although tumor diathesis is a key cytologic feature for invasion, not all invasive tumors are accompanied by a tumor diathesis. In keratinizing squamous cell carcinomas, most of these tumors form exophytic tumor masses. So in these cases are more likely to have a clean background than deeply invasive tumors. 3 different cases of keratinizing squamous cell carcinomas are shown here. It's obvious that highly keratinized atypical cells are present in all 3 cases. Marked keratinized cytoplasm are not sufficient for the interpretation of carcinoma in the absence of tumor diathesis. In this picture, we see keratinized cells with slightly enlarged nuclei with an hyperchromatic chromatin pattern. If the cells are limited to these features, and if they are few in number, then you may prefer to call such cases as atypical squamous cells undetermined significance ASCUS. And follow-up of this case showed low-grade squamous intraepithelial lesion. And here in this picture, we see keratinized cells with marked pleomorphism. Some of these cells have pyknotic nuclei with high NC ratio. There's this variation in cell size and shape, and all of these features are suggesting a high-grade squamous lesion, and follow-up of this case showed a high-grade squamous intraepithelial lesion. And in this picture, again, we see highly keratinized cells with hyperchromatic nuclei. Besides these keratinized cells, an adjacent small size cell group is present with a high NC ratio. In the background, broken down blood elements are present, and all of these features suggesting an invasive cancer. And the follow-up of this case showed that squamous cell carcinoma. As we see in these three different cases, keratinized cytoplasm can belong to a low-grade lesion, high-grade lesion, or invasive cancer. In non-keratinizing squamous cell carcinomas, nuclei demonstrate markedly irregular distribution of porosely clamped chromatin pattern with chromatin clearing, and comparing to keratinizing form in non-keratinizing squamous cell carcinomas, tumor diathesis is often present in these cases. In some cases, the diathesis can be so extensive and it can dilute or obscure the diagnostic elements. In such pap smears, close screening for rare abnormal cells is indicated. After close viewing the pap smear within a background of tumor diathesis, if there are only limited numbers of abnormal cells are found, then the diagnostic category should be high-grade squamous intraepithelial lesion with features suspicious for invasion. And here we see two different cases which exhibit such features, and follow-up of these two cases show a squamous cell carcinoma. We need to remember that tumor diathesis alone is insufficient for diagnosing a case as cancer. Cancer cells must also be identified. Also, we need to remember that when the high-grade squamous intraepithelial lesions involve the endocervical glands, focal necrosis can be present, which is linked to the atypical cells, and this may be misdiagnosed as tumor diathesis with invasive cancer. And we have such two cases here. In the left side, highly atypical cells with increased NC ratio with a clinging tumor diathesis is present. And in the right side, atypical cell with a keratinized cytoplasm in the background of tumor diathesis is shown. And both of these cases show a high-grade squamous intraepithelial lesion with glandular involvement in the follow-up. Several benign processes can be associated with a background that closely mimics a tumor diathesis. One of them is an atrophic smear, a granular, diffuse granular proteinous material can be present in severely atrophic samples in postmenopausal women, which can mimic tumor diathesis. Also, cases of the irritated endocervical polyps, which often have areas of surface ulceration, may show necrotic inflammatory debris. Lubricant material can stimulate diathesis with granular material, which cling to the cells and resembling and clinging diathesis. In such cases, tumor diathesis alone is insufficient. Evidence for unequivocal interpretation of cancer. Cancer cells must also be identified. And in the absence of cancer cells, despite careful search, this means all of these features favors a benign interpretation. After finishing squamous cell carcinomas, I will end my presentation with take-home messages within a few slides. Remember that small size atypical cells are the feature for high-grade lesions, and bigger atypical cells are the features for low-grade lesions. When you find a lot of small size atypical cells in a smear, the diagnosis will be high-grade squamous intraepithelial lesion. If you find rare small size atypical cells or the atypical cells have subtle nuclear features for a high-grade lesion, then you can call these cases as ASCH. Prominent nucleoli favor reactive conditions or invasive carcinomas rather than squamous intraepithelial lesions, but high-grade squamous intraepithelial lesions with endocervical glandular involvement may exhibit prominent nucleoli. Tumor diathesis is an important key feature for invasive lesions, but in high-grade squamous intraepithelial lesions with endocervical glandular involvement, you can see tumor diathesis, which cling to the atypical cells. Marked keratinized cytoplasms are not only the feature for squamous cell carcinomas, also in low-grade and high-grade squamous intraepithelial lesions, we can see keratinized cytoplasm in the atypical cells. And this was my last slide. I want to thank all to you for attending this presentation.
Good afternoon. I am Dr. Pınar Uyar Göçün from Gazi University Faculty of Medicine, Department of Pathology. Today I will talk about atypical glandular cells. I have no conflicts of interest to disclose. The outline of my presentation is like that. First of all, I will talk about glandular cells and then glandular cell abnormalities, mimickers of atypical glandular cells, and reporting rates and follow-up and management of AGC. During my presentation, I will show you cases from Bethesda Atlas and from archive of my department. In 1994, the Bethesda System for Reporting Cervical and Vaginal Cytologic Diagnosis book was published, and after 10 years, the second edition had come. At 2014, the third edition was published. The PAP test was not designed to screen for glandular lesions of the cervix, and these abnormalities are more difficult to sample and interpret compared to their squamous counterparts. However, because of improvement in sampling devices and the increase in endocervical adenocarcinoma relative to squamous cell carcinoma over the past 2 decades, cytologists currently encounter more challenging presentations of glandular lesions and their mimics in cervical cytology specimens. Here we see endocervical cells and endometrial cells. On the left side, the endocervical cell size is larger than endometrial cell, and their cytoplasm is abundant and their nucleus is oval or elongated. Whereas endometrial cells are smaller, their cytoplasm is generally scant and nucleus is round. Here we see the mucinous endocervical epithelium. Here we see the honeycomb arrangement and columnar cell arrangement, and on the right side we see endometrial cells. They are more hyperchromatic groups and they have round nucleus and scant cytoplasm. According to the Bethesda reporting system, the glandular cell abnormalities are categorized as atypical endocervical, endometrial or glandular cells, NOS or specify in comments, atypical endocervical cells, favor neoplastic, or glandular cells favor neoplastic. The third category is endocervical adenocarcinoma in situ, and the fourth category is adenocarcinoma, endocervical, endometrial, extrauterine, or not otherwise specified. Atypical glandular cells are not classified as AGUS because this leads confusion with ASCUS. Atypical endocervical cells and atypical glandular cells are classified as NOS or favor neoplastic. We don't use favor reactive because favor reactive is considered to be potentially misleading and therefore is not included in Bethesda terminology. Atypical endometrial cells are not further qualified as to favor neoplasia, reflecting the difficulty in reliable further subclassification of this category. Similar human papilloma virus types have been demonstrated in most but not all endocervical adenocarcinomas and endocervical adenocarcinoma in situ. The proportion of adenocarcinomas associated with HPV-18 is larger than for squamous cell carcinoma. What is atypical glandular cells NOS? Cells resembling endocervical cells with nuclear atypia that exceeds the reactive or reparative process but lack unequivocal features of endocervical adenocarcinoma in situ or invasive adenocarcinoma. Whenever possible, the location of origin of cells has to be specified, like as endocervical or endometrial. Here we see a picture. These are endocervical cells showing nuclear enlargement, crowding and overlap, and increased NC ratio, and also we see mitotic figures. This case was diagnosed as atypical glandular cells NOS, and 3-year follow-up showed negative for intraepithelial lesion or malignancy. Atypical glandular cells NOS diagnostic criteria are cells occurring in sheets and strips with crowding, overlapping nuclei and pseudostratification, enlarged nuclei up to 3 to 5 times of the normal endocervical cells, some variation in nuclear size and shape, mild nuclear hyperchromasia, mild irregularity of chromatin, rare nucleoli, rare mitotic figures, abundant cytoplasm with a fairly increased NC ratio, and distinct cell borders. Here, endocervical cells showing nuclear enlargement, marked variation in nuclear size and nuclear crowding and overlap is seen, and follow-up of this patient was negative for intraepithelial lesion or malignancy. Here we see a case. This is a conventional pap test from a 30-year-old female. We see superficial and intermediate cells and neutrophil leukocytes in the background. There is an endocervical cell group here. We see some nuclear enlargement and overlapping and crowding here, and the mitotic figure also. And here is the columnar cell arrangement and honeycomb arrangement, but here in the center of the slide we see a more crowded endocervical group with some nuclear enlargement, and we see neutrophil leukocytes in the group. So this is a papillary cell group with nuclear hyperchromasia and some overlap. Again, here we see nuclear enlargement and some overlapping. So we diagnose this case as atypical endocervical cells NOS. And in the biopsy specimen, we saw papillary cervicitis with some nuclear enlargement and then inflammatory cells in the stroma, and also nuclear hyperchromasia and some crowding of the cells. Here is another case from a 44-year-old female. We see hyperchromatic three-dimensional group, and we can see hyperchromatic nuclei and high NC ratio at the periphery of the group. In the center, there are overlapping, and we can't understand the nuclear or cytoplasmic details. And if you do fine adjustment, you can understand nuclear or cytoplasmic details. So these cells have hyperchromatic round nuclei and scant cytoplasm. These are endometrial cells. And we can see hyperchromatic small groups here with some overlapping and increased NC ratio. And there is another population here. These are metaplastic cells with cytoplasmic elongations. And also there is hyperchromasia here. And hyperchromasia, some overlapping is seen. And the biopsy of this patient showed mixed endocervical and endometrial polyp. You can see the stratified epithelium. Some of the nuclei are round, some of them are columnar shaped. And you can see tubal metaplasia in the epithelium. So what are the mimickers of atypical endocervical cells NOS? Here we see hyperchromatic cell group with pseudostratification and the cilia at the edges, and we can see the P16 patchy staining in the biopsy specimen. This was a tubal metaplasia. Here we see endocervical cells showing nuclear crowding and overlap and nuclear enlargement. This case was diagnosed as atypical endocervical cells NOS, and follow-up was tubal metaplasia. Here we see endocervical cells with nuclear hyperchromasia, crowding, pseudostratification, and increased NC ratio. If you look carefully, we can see cilia and the terminal bar, and this is likely representing tubal metaplasia in which cilia are not well visualized. And here is another case from our archive. These are columnar cells with pseudostratification and hyperchromasia. There is some overlapping, and this was a tubal metaplasia case. You can see the cilia at the periphery. The second mimicker is reactive endocervical cells with IUD effect, intrauterine device effect. We see endocervical cells showing nuclear enlargement, nucleoli, and cytoplasmic vacuolization. If there is no clinical history of IUD, these changes would be considered atypical glandular cells. Another mimicker is radiotherapy effect. We see large cells with cytoplasmic vacuolization, multinucleation, smudgy chromatin. NC ratio is not increased, and clinical history is very important in giving the diagnosis radiotherapy effect. Another mimicker is Aristella reaction. We see endocervical cells with high NC ratio and prominent nucleoli. And on histology, cells have nuclear size variation, smudgy chromatin, and vacuolated cytoplasm. Clinical history and background acute inflammation are clues to consider this condition. And in conventional preparations, large fragments containing both glandular and stromal elements are common in examples of lower uterine segment sampling. In many cases, distinction of glands from stroma is challenging. Here we see glandular epithelium, and on the right side we see stromal component. High-grade squamous intraepithelial lesion involving endocervical glands can mimic the appearance of a glandular lesion by presenting as contoured clusters of tightly packed cells. In addition, nucleoli are often visible when high cell involves glands. Here is a case from our archive. It's a conventional pap test from a 40-year-old female. We see these hyperchromatic nuclei with scanned cytoplasm. They are squamous cells. There is nuclear membrane irregularity and high NC ratio. And here we see a crowded group with hyperchromatic overlapping nuclei. It seems like glandular cells. And here we see the nuclear hyperchromasia, some nuclear enlargement, and overlapping. This is high cell involving endocervical glands. And the patient's biopsy showed us high cell in the squamous epithelium and also endocervical gland involvement. We performed chromogenic in situ hybridization for high-risk HPV, and high-risk HPV was positive in both the squamous epithelium and the glandular epithelium. Here is another case from a 55-year-old woman. We see superficial and intermediate cells and neutrophil leukocytes in the background, but we see hyperchromatic crowded groups. When we see these kind of groups, we have to be aware of squamous intraepithelial lesion cells, so we'll look for them. This group is a tightly packed hyperchromatic crowded group with overlapping nuclei, and we see some hyperchromatic nuclei in the background. they have high NC ratio. So these cells can be high SIL, and these hyperchromatic group can be high-grade SIL involving endocervical glands. It's tightly packed, hyperchromatic, overlapping nuclei. And this is a high SIL cell. And these are high SIL cells. So this case was diagnosed as high SIL with endocervical gland involvement. And the biopsy showed again high SIL and endocervical gland involvement like that. And the second category is atypical endocervical cells favor neoplastic. When glandular cells with morphology either quantitatively or qualitatively falls short of interpreting as endocervical adenocarcinoma in situ or invasive adenocarcinoma, we diagnose as atypical endocervical cells favor neoplastic. Here we see a hyperchromatic crowded cell group with some nuclear palizading at the periphery of the group. What are the diagnostic criteria for atypical endocervical cells favor neoplastic? Cells occurring in sheets and strips with nuclear crowding, overlap, and/or pseudostratification, cell groups resembling rosettes or forming glands or feathering, enlarged and elongated nuclei with hyperchromasia, coarse chromatin with heterogeneity, occasional mitosis and/or apoptotic bodies, increased NC ratio, and ill-defined cell borders. Here in this case, we see a sheet of endocervical cells with high NC ratio, nuclear crowding, overlap, pseudostratification, and feathering at the edges. This case was diagnosed as adenocarcinoma in situ in follow-up. Here in this case, we see endocervical cells with nuclear enlargement, oval nuclei, disordered arrangement with overlapping nuclei, and forming a rosette-like gland. This case shows some but not all features of endocervical adenocarcinoma in situ and is thus best interpreted as atypical endocervical cells favor neoplastic, and follow-up of this patient was adenocarcinoma in situ. Atypical endometrial cell distinction from benign endometrial cells is mainly based on the increased nuclear size in the atypical cells. We don't classify the atypical endometrial cells as favor neoplastic because it often gives poorly reproducible results. What are the diagnostic criteria? We see cells in small groups, usually 5 to 10 per group, slightly enlarged nuclei in comparison to normal endometrial cells, mild hyperchromasia, chromatin heterogeneity, occasional prominent nucleoli, scant vacuolated cytoplasm, and ill-defined cell borders. Here we see a case from a postmenopausal woman with bleeding. The three-dimensional arrangement of cells with hyperchromatic nuclei and scant cytoplasm are indicative of endometrial origin. Nuclear size enlargement is the main criteria for atypia in endometrial cells, and these groups may present as tight clusters or looser aggregates. The follow-up of this patient was endometrial hyperplasia. Endocervical adenocarcinoma in situ, AIS, is a high-grade endocervical glandular lesion without invasion with nuclear enlargement, hyperchromasia, stratification, and mitotic activity. It is approximately 100% related to HPV infection. Type 18 is more common than type 16. They arise in endocervical and transformational zone glands. Superficial and glandular epithelium is involved, and colposcopy is usually normal in these patients. We see crowded groups, rosettes, palisades, oval or elongated nuclei, indistinct nucleoli, granular cytoplasm, and clean or bloody background. Here is rosette-like arrangement with overlapping and crowding and nuclear pseudostratification, and also feathering at the edges of the group. We see oval nuclei, they are hyperchromatic, and these are all AIS cases. Sometimes adenocarcinoma in situ can show nucleoli that raises the possibility of invasive adenocarcinoma. This is another case from our archive. It's a SurePET preparation from a 37 years old female. We see superficial and intermediate cells and neutrophil leukocytes in the background. And also we see a small hyperchromatic group here and another larger hyperchromatic group here. We can see some pseudo-stratification and feathering-like changes. We can't understand the nuclear detail and cytoplasmic detail of this group, but we can say it's hyperchromatic and NC ratio is increased. So this case was reported as AGC, fever neoplasia. And the biopsy of the patient showed adenocarcinoma in situ, like that. And we can see diffuse P16 staining and high Ki67 proliferation index. This is another case from a 38 years old female. This is a SurePET preparation. We see hyperchromatic crowded groups, small groups, and also large groups are seen. There is stratification and also feathering. We see heterogeneous chromatin patterns. Some of the cells show their nucleoli. There is hyperchromasia, overlapping. And you can see the heterogeneous chromatin pattern here. It's a three-dimensional group. We see three-dimensional groups in liquid-based preparations. There are small groups and larger hyperchromatic groups. So with the stratification, nuclear hyperchromasia, heterogeneous chromatin pattern, we can say that this case is adenocarcinoma in situ. And the biopsy showed adenocarcinoma in situ. The hyperchromatic cells with nuclear elongation, stratification, and also mitotic figures can be seen. There are not distinct nucleoli, but the chromatin pattern is heterogeneous. You can see diffuse, strong P16 staining. Coexisting squamous and glandular lesions are not uncommon. In this case, we can see high cell on the left and adenocarcinoma in situ in the right side. Usually, we can see them together on biopsies. Here in this cytology specimen, we can see high cell cells and maybe low cell cells here, but on the bottom we can see hyperchromatic small cells forming a group, and this is an endometrioid type adenocarcinoma in situ. Here is an intestinal type adenocarcinoma in situ. It's a very rare variant. We can see goblet type cells as well as nuclear crowding, overlapping, and hyperchromasia. The endometrioid variant of endocervical adenocarcinoma in situ shows smaller nuclei compared to traditional AIS, which can lead to a mistaken interpretation as directly sampled endometrium. Endocervical adenocarcinoma's diagnostic criteria are abnormal cells with columnar configuration, single cells, two-dimensional sheets or three-dimensional clusters and syncytial aggregates. Enlarged pleomorphic nuclei demonstrate irregular chromatin distribution, chromatin clearing, and nuclear membrane irregularities. Macronucleoli can be seen. As you can see here, there is macronucleoli, cytoplasmic vacuolization, and there is a bloody tumor diathesis in the background. Here, cytoplasm is finely vacuolated and necrotic tumor diathesis is common. Abnormal squamous cells may be present, representing a coexisting squamous lesion or the squamous component of an adenocarcinoma showing partial squamous differentiation. Tumor diathesis may be less prominent in liquid-based preparations and appears as a debris clinging to the periphery of the cell clusters. Follow-up of this patient was invasive endocervical adenocarcinoma. Gastric type endocervical adenocarcinoma, in other words, adenoma malignum, is most readily identified on histology by deep infiltrating growth. The abundant cytoplasm and minimal nuclear atypia make recognition of malignancy on cytologic grounds challenging. Here you can see the columnar-shaped mucinous epithelium. They resemble endocervical benign cells. This is a case of a 73-year-old female. It's a conventional pap smear. We see tumor diathesis in the background. There is a necrotic tumor diathesis. And also we see a crowded hyperchromatic group here with high NC ratio. Their cytoplasm is not scanned. We don't see nucleoli here. And here we have another group. They resemble squamous cells, but their cytoplasm is a little vacuolated. And we diagnose this case as atypical glandular cells favor neoplasia. And the biopsy showed clear cell carcinoma in cervical os. Endometrial adenocarcinoma cells typically occur singly or in small tight clusters. Cytoplasm is typically scant, cyanophilic, and often vacuolated. In well-differentiated tumors, nuclei may be only slightly enlarged compared to non-neoplastic endometrial cells and becoming larger with increasing grade of the tumor. Variation in nuclear size and loss of nuclear polarity can also be seen. You can see cytoplasmic vacuolization and nuclear enlargement hyperchromasia and visible nucleoli. Small to prominent nucleoli can be seen, and nucleoli become larger with increasing grade of tumor. Intracytoplasmic neutrophils can be seen, and nuclei display moderate hyperchromasia, irregular chromatin distribution, chromatin clearing, especially in high-grade tumors. A finely granular or watery tumor diathesis is variably present, most commonly in conventional smears. We can see the watery diathesis in the background. Here we see a papillary group with hyperchromatic nuclei. NC ratio is a little increased, and we can see distinct nucleoli. These cells resemble ovarian serous carcinoma, and the follow-up of this patient was uterine serous carcinoma. Tight cluster of glandular cells with a papillary configuration and nuclear enlargement and small but prominent nucleoli are seen. In liquid-based preparations, endometrial adenocarcinomas more commonly show three-dimensional clusters with a papillary configuration compared to conventional preparations. Follow-up of this patient was endometrial adenocarcinoma, endometrioid type, and grade 1-2. Endometrial adenocarcinomas often show isolated or small groups of cells with intracytoplasmic vacuoles, intracytoplasmic neutrophils within a prominent vacuole, the so-called bag of Polis appearance. And follow-up of this patient was endometrial adenocarcinoma, endometrioid type. Here is a conventional pap smear from a 51-year-old female. We see watery tumor diathesis in the background and hyperchromatic small tight group, and also smaller groups and single cells are seen in the background with hyperchromatic nuclei and enlarged nuclei. NC ratio is increased. There is nuclear membrane irregularities. And this case was diagnosed as endometrial adenocarcinoma. The biopsy showed endometrioid type endometrial adenocarcinoma, grade 2. And another case is a SurePath preparation from a 63-year-old female. We see intermediate cells and also parabasal cells. Some of the cells have cytoplasmic vacuolization, and also there is a hyperchromatic group here with high NC ratio, round nucleus, and heterogeneous chromatin distribution, like as here. And we see a smaller hyperchromatic group here. These cells resemble endometrial cells, and this is an endometrial adenocarcinoma. The biopsy showed endometrioid type endometrial adenocarcinoma grade 3. You can see the visible nucleoli. And extrauterine adenocarcinoma, we see adenocarcinoma cells in a clean background and an unusual morphology for cervix and uterus adenocarcinomas. They can be from ovary and fallopian tube. We can see degenerative changes, metastasis or direct extension can occur. Vast majority from colon and bladder. Breast cancer can also be. Here we see hyperchromatic group with high NC ratio, elongated nuclei, and heterogeneous chromatin distribution. This patient had colon adenocarcinoma. And this is a case with some MOMA bodies. This patient had ovarian adenocarcinoma. And here we see atypical cells with high NC ratio, hyperchromatic nuclei. This patient had gastric adenocarcinoma. Also, metastatic breast carcinoma can be seen. Here we see a lobular carcinoma metastasis. You can see the cytoplasmic vacuole, and we can see these small hyperchromatic groups. With the clinical history, when you perform immunocytochemistry for estrogen receptor and gross cystic disease fluid protein 15, they are stained, and this is a breast carcinoma metastasis. Here you see a hyperchromatic crowded papillary group, and in liquid-based preparations, papillary clusters from ovarian carcinoma can be three-dimensional, leading to difficulty evaluating the individual cells for atypia. This is from an ovarian serous carcinoma. Here is another case from our archive. It's a 37-year-old female with a history of colon adenocarcinoma. We can see lots of neutrophil leukocytes in the background and the hyperchromatic group here. The nuclei are hyperchromatic, NC ratio is increased. There is columnar configuration and also gland-like configuration. The chromatin pattern is heterogeneous, and you can see that there are lots of neutrophil leukocytes in the background and also nuclear crowding here, overlapping. And this tumor was diagnosed as extrauterine adenocarcinoma, probably colon adenocarcinoma with the clinical history. And at the same time, the patient had transverse colon biopsy. We can see radiation-induced changes in these atypical glands, but also these invasive glands are seen. And CDX2 and cytokeratin 20 were positive in this case. Another case from a 58-year-old female, we see lots of neutrophil leukocytes in the background and a papillary group here, and gland-like formations with high NC ratio and distinct nucleoli. The papillary projections, high NC ratio, and hyperchromatic overlapping nuclei are seen. You can see the distinct nucleoli here. So this case was diagnosed as adenocarcinoma, NOS, and the patient had high-grade serous carcinoma of left ovary. And this is another case from a 65-year-old female. It's a SurePET preparation. We can see hyperchromatic crowded groups with high NC ratio, and also in the background we see single cells and small groups. And this case showed distinct nucleoli. When you do fine adjustment, you can see the three-dimensional groups show their some nuclear features. There is hyperchromasia, high NC ratio, heterogeneous chromatin distribution, and some distinct nucleoli. And this case was diagnosed as mixed clear cell carcinoma and serous carcinoma from right ovary. So the cytologic features of endocervical, endometrial, and extrauterine carcinoma have some similarities and differences. Endocervical adenocarcinomas are hypercellular. There are strips, rosettes, sheets with feathering and single malignant cells. Tumor diathesis is visible and type varies by preparation. Cell shapes are oval, columnar and pleomorphic. Nuclei are oval, elongated, pleomorphic or vesicular. Cytoplasm contains mucin. High cell or squamous cell carcinoma present in more than 50% of cases. High-risk HPV is positive in most of the cases, and P16 is diffuse and strong positive. Endometrial carcinoma have low cellularity usually. There are small clusters, rarely papilla, single cells. Tumor diathesis is variable, is watery or subtle or absent. Cell shapes are round, irregular, usually smaller. Nuclei are round or irregular in higher grade. Cytoplasm has degenerative vacuoles. High cell or squamous cell carcinoma is absent. High-risk HPV is negative. P16 staining is patchy or focal, except in high-grade or serous tumors. Extrauterine carcinoma contains rare cells unless direct extension. The pattern varies depending upon primary and mode of spread. Tumor diathesis is usually absent unless direct spread or metastasis. Cell shapes are variable and nuclei, cytoplasm are variable. There is no high-grade squamous intraepithelial lesion or squamous carcinoma. High-risk HPV is negative and P16 is variable, depends on the type of the tumor. And according to the College of American Pathologists report, atypical glandular cell reporting rates in 50% of laboratories is 0.1 to 0.2%, and it varies between 0 to 0.8%. And follow-up of atypical glandular cell lesions is mostly high-grade squamous intraepithelial lesion. In the literature, we can see that the rates are different from each other, but they are not very common. And most of the lesions are squamous intraepithelial lesion, and also adenocarcinoma in situ, endometrial hyperplasia, and carcinoma are seen in atypical glandular cell groups. This is a study from Hacettepe University. They had 80 cases, which was reported as atypical glandular cells in cytology. And in histopathologic results, we can see that 66% of the patients had non-significant lesions, whereas 33% had significant pathology. And the most common pathology was endometrial adenocarcinoma, followed by cervical squamous cell carcinoma, cervical adenocarcinoma, and high cell. So, according to the American Society for Colposcopy and Cervical Pathology 2019 consensus guidelines, if a patient has atypical glandular cells, atypical endocervical cells, NOS, or favor neoplasia, colposcopy and endocervical sampling must be done. If the patient is 35 years or older, also endometrial sampling is needed. But if the patient is less than 35 years old, but has higher risk for endometrial carcinoma, then endometrial sampling must be done. If there is negative colposcopy and endocervical sampling in AGC-NOS group, then you can repeat cytology at 12 and 24 months with high-risk HPV testing. And suppose negative should be co-tested every 3 years. If any abnormality is detected, colposcopy is needed. AGC favor neoplasia needs colposcopy and endometrial sampling, and if it is negative, then perform cone biopsy. Atypical endometrial cells need endometrial sampling and endocervical sampling. Colposcopy may be delayed if endometrial pathology is identified in these patients. And as a summary, cervical cancer screening is a powerful tool and has greatly impacted the outcomes of cervical cancer in women. Atypical glandular cells include a wide variety of conditions which range from reactive conditions to dysplasia and to carcinoma. AGC is the term used when the nuclear features are more worrisome than usually seen in reactive conditions, but not enough to call it malignant. More than 50% of the women diagnosed with AGC have no pathology on colposcopy and subsequent endometrial sampling. In patients with AGC favored neoplastic, if the colposcopy and endometrial sampling are negative, it doesn't exclude malignancy. A cone biopsy is the next recommended step, and it is the responsibility of the treating physician to conduct a thorough examination and diagnostic workup. Thank you very much for your attention.
Hi, my name is Burcu Özcan. Now we are going over 3 pap smear cases. All materials were prepared by liquid-based cytology. One of them was prepared by TeamPrep and the other 2 with SurePet. This first one is a SurePet case. Now let's start. It belongs to a 34-year-old woman. It looks satisfactory for evaluation at first sight. The number of squamous cells looks enough, but we have not seen the transformation zone component yet. The majority of cells consist of mature cells, especially intermediate cells. And this is what we expect for a woman in the reproductive age. There are a few neutrophils in the background, and in some areas, these neutrophils compose neutrophil balls. And another finding is perinuclear halos. These halos are narrow and have indistinct borders. When we look closer, we can see that the cytoplasm of some of the superficial and intermediate cells appear a little bit blurry. On closer examination, we notice numerous elliptical or kite-shaped organisms on these cells. They have a little elliptical nuclei. Some of these organisms also present in the spaces between the cells, like these, and these ones are looking more degenerated. This is a typical case of Trichomonas mones vaginalis with perinuclear halos and neutrophil balls and organisms covering the cell surfaces. And we reported this smear as negative for intraepithelial lesion or malignancy, and we added organism morphologically consistent with Trichomonas vaginalis. The perinuclear halos and the neutrophil balls were the clues think it may be a Trichomonas vaginalis case, and this was my first case. Now we are moving on to my second case, which was sampled from a 42-year-old woman. We don't have any clinical information as usual. This was prepared by Team Prep. When we zoom in, we see mature cells, especially superficial cells. We haven't seen the transformation zone component yet. There are bacterial organisms on cell surfaces and a granular dirty debris in the background intermixed with neutrophils. We haven't seen any nuclear atypia yet. The nuclei are small and pigmentic. There are some darker cells which we can't observe the nuclear details, like this. Like there is a multinucleation here, but we can't detect the nuclear details. Let's look the ones which are marked before. Let's start with this one. This cell is multinucleated, and the nuclei are molding with each other. There is a little bit margination of the chromatin, and the nuclei looks have a ground glass appearance. Let's check the other ones. Here there is another multinucleated cell, and the ground glass appearance is very significant that we can't see the details. Here we have another cell with a huge nucleus, and the margination is chromatin is significant in this cell, and we see the ground glass appearance. This cell looks like it has the same features like the others, multinucleation and molding of the nuclei. And in some of the nucleus, we see a little dense body inside. Yes, here this cell have 3 nuclei, and there is a internuclear inclusion here and molding again. Another multinucleated cells with molding of the nuclei and ground glass appearance. This is a typical herpes simplex virus case. Considering all these findings together, which are they? Multinuclear cells with nuclear molding and ground glass appearance, and internuclear inclusions. This case was reported as negative for intraepithelial lesion or malignancy with the presence of an organism consistent with herpes simplex virus. My third case is a smear which was sampled from a 65-year-old woman who complained of postmenopausal bleeding. and this smear is highly cellular compared to the other ones. We see the cells are having three-dimensional clusters, and it's difficult to detect their nuclear details in these clusters. Let's look closer to these clusters. They have rounded outlines, and there are some cells scattered in the background. These cells look very atypical because they have large nuclei and they have coarse chromatin. Some of the cells have larger abundant cytoplasm, but some of them have scanty cytoplasm. In the background, we see debris, granular debris. It looks dirty. The cells have different sizes and shapes. Some of them are multinuclear. Some of them have vacuoles in their cytoplasm. Sometimes they overlap on each other. An intracytoplasmic vacuole. Some of them have neutrophils in their cytoplasm. I will show you when I find. They look very atypical and pleomorphic, and we think they are malignant. There is a large vacuole in the cytoplasm. We think it's malignant, but is it a squamous cell carcinoma or an adenocarcinoma? We don't see the features of squamous cells like keratinization, hyperchromatic, ink dot-like nuclei. Rather, we see three-dimensional clusters with rounded outlines. We see intracytoplasmic vacuoles in some cells, and these findings make us think it's a glandular malignancy. Now, is it originated from endometrium or endocervical? We don't have pseudostratified cells with columnar cell shaped, and this make us think it is not originated from endocervical cells. Cytoplasmic vacuoles and neutrophils make us think it's a endometrial originated malignancy. Unfortunately, this patient had undergone endometrial curettage, and a diagnosis of serous adenocarcinoma was made on her endometrial curettage, and we reported this case as adenocarcinoma with endometrial origin. Vacuolated cytoplasm is a very important clue for the original site. And that was my last case. And thank you for your patience.
Hello, dear colleagues. I'm Şenay Erdoğan Durmuş. My first case was 55 years old. A liquid-based cytology preparation sample, a shrew PET. We see superficial cells, intermediate cells, and they are normal. Endocervical cells, they are normal too. And in some areas, we see 3D groups in this magnification, just like this. And here we can see again 3D groups, hyperchromatic. They have hyperchromatic nuclei, nucleoli. And in here, we see 3D group, vacuolate cytoplasms, macronucleoli. We can see in some cells. And these are atypical glandular cells. We can see here again 3D group, macronucleoli in 2 of cells, and vacuolate cytoplasms. A macronucleoli we can see in these cells. 3D group, vacuolate cytoplasms, and hyperchromatic nucleoli, and nucleocytoplasmic ratio was increased. These are atypical glandular cells, should be diagnosed as adenocarcinoma, but these cells don't like endometrial or endocervical cells. Meanwhile, we had the chance to obtain clinical information. We learned that the patient has a right ovarian mass, 8 centimeter in size. We applied immunohistochemistry to the additional acute-based preparatory slides. This is we prefer PAX8 and WT1 for showing ovarian origin. And also these markers are nuclear markers that are very suitable for immunohistochemistry. This is PAX8. We can see the strong positivity in tumor cells with PAX8 here and here. And here. Very strong and nuclear positivity for PAX8. And I want to show WT1. Again, it's strongly positive, nuclear positive in tumor cells. Here. And here. And here. These are tumor cells. We have macronucleoli again in these cells, in 3D groups they have. We can easily separate them from the normal cells. And this one again, WT1 positive tumor cells. With histomorphological findings and immunohistochemistry results, we diagnosed the case as atypical glandular cells and adenocarcinoma, and consistent with ovarian carcinoma metastasis. My second case was 58 years old, a acute-based cytology preparation sample again. We see so many crowded dark groups from this magnification. And in detail, we see so many crowded groups, hyperchromatic. Mostly they have oval nuclei with distributed coarse chromatin, coarsely granular chromatin. In most areas, there is nuclear overlapping. We can see them. In some areas, prominent gland-like configuration, rosette, like rosettes. And we can also see pseudo-stratified strip cells, demonstrating crowding, nuclear enlargement. And we can also see cytoplasmic tags protruding from the periphery that called feathering. And we can talk about loss of a well-defined honeycomb pattern. This is a honeycomb pattern, but we don't see in these cells, junior cells. And in liquid-based preparation, we can see these crowded groups more smaller, denser, and more three-dimensional with smoother, sharp margins, just like here. And we can see nucleoli more, maybe more readily visible in liquid-based preparations. In this case, it's atypical glandular cells and adenocarcinoma in situ. Follow-up showed adenocarcinoma in situ too. I want to show more details from other areas. Here. Hypochromatic, granular, coarsely granular chromatin, we can see. And here, pseudostratified strip of cells with crowding. Mostly we see crowded groups and dark groups, darker 3D crowded groups. This again, you can see here nucleoli for this case. Here, a demonstrative sample for adenocarcinoma in situ, and feathering. Again, we can see from these cells. In some areas, the crowded cells are we have so many crowded cells, so we can't see the detail of cells in these areas, especially in these areas. My third case was 48 years old, a liquid-based cytology preparation sample, a sure PET again. We see so many isolated cells in sample. We see so many spindle cells with orangeophilic cytoplasm, cells with irregular nuclear contour and high nucleostoplasmic ratio, and keratotic cells that we can see. All of our legionnaire cells, and I put some samples for find easily. These cells are spindle cells, nucleus cytoplasmic ratio is high, and orangophilic cytoplasms they have. And again, in this area, they have irregular nuclear contours, hyperchromatic, orangophilic cytoplasm, and keratotic changes associated with keratotic changes. Again, an atypical orangophilic, hyperchromatic, and coarse chromatin we can see in this case. And in every area we can see spindled tadpole like cells, and we see debris in background, and we see so many irregular cells, and nucleus cytoplasmic ratio is high. They are hyperchromatic, and apoptotic cells in here. And nucleus cytoplasmic ratio is very high. In some of them, it's very irregular, and they have coarse chromatin. And keratotic changes in here. Again, we see spindle atypic cells with orangophilic cytoplasm. And in here we can see alveolar debris and necrotic cells in background. So we can talk about tumor diathesis also. This case was diagnosed as squamous cell carcinoma, keratinizing type, and the follow-up biopsy revealed invasive squamous cell carcinoma too. We can see in all areas tumor cells like this, and a very demonstrative case for squamous cell carcinoma. We can see these orangophilic, coarse chromatin, hyperchromatic cells. And I want to share this very demonstrative case with you. Thank you.
Hi, everybody. In this part, I will represent you 3 cases. The first case is 31 years old woman without a specific history. Firstly, here in this part, we see 2 cells with atypical features. Let's remember our first rule. Firstly, we need to decide whether these cells are atypical or not. Then, if we decide that the cells are atypical, we will grade the dysplasia. So, to understand the presence of dysplasia in these 2 cells, we need to compare the nuclei of these cells with an intermediate cell nucleus. And then intermediate cell is present here in this point. Comparing to the intermediate cell, similar size or slightly enlarged size is present in the nuclei of these 2 cells. There's a slight hyperchromasia with a slight nuclear contour irregularity is present. These cells have a small size with a scant cytoplasm, increase-and-see ratio, distinct cell boundaries, and the dense cytoplasm indicate squamous nature. Due to small size, without atypia in such cells, metaplastic cells should be in the differential diagnosis, but with a slight atypia in these cells, high-grade lesions also needed to be remembered in such cases, in such cells. When you see such features in a case, careful evaluation of the remaining slide is mandatory in such cases. And after searching the slide, we found other two cells that have similar features. The end circle showing us two cells that have distinct cell borders with dense cytoplasm, which indicates schema's nature in these cells. Comparing to the adjacent intermediate cell, there's a slightly increase in the size of the nucleus, and slight hyperchromasia is also evident, but the nuclear contours are irregular in these cells. Due to dense cytoplasm, due to small size, a metaplastic cell or an high-grade dysplasia, dysplastic cells can be present here. When such subtle features for atypia are present in small size cells, you should diagnose such cases as ASCH. Two other cells that resemble the previous ones are present, but comparing to the previous ones, more irregularity in the nuclear membrane is present in these two cells. Again, similar features are suspicious for a high-grade lesion, so with such features, ASCH should be preferred. A small cluster of cells are seen here. Comparing to an intermediate cell nucleus, there's a slightly increase in the size of the nucleus in these cells. A coarser chromatin pattern is present. A slight hyperchromasia is also evident, and some nuclear contour irregularity is present in some of these cells. With all of these features, dysplasia is suspected in such cases. But comparing to the previous one, the size of these cells is not as small as the previous ones. They are larger cells. They are lying in an intermediate category between a high-grade lesion and between a low-grade lesion. Here, the circle showing us two different types of cells. Firstly, we will talk about this one. Comparing to the previous ones, atypia is more prominent in these cells. Comparing to intermediate cells, there's a coarser chromatin pattern with increase in size, hyperchromasia also evident, and the size of these cells, again lying between a high-grade lesion and a low-grade lesion. But with these features, the best category in such cases should be a low-grade squamous intraepithelial lesion. And after focusing on this group, let's focus on these dispersed cells. These cells also have a slightly enlarged nuclei with nuclear contour irregularity and hyperchromasia. But comparing to this one, these dispersed cells have scant cytoplasm, they have small size, and increased NC ratio. This group may represent a low-grade lesion, but these dispersed small size cells are suspicious for a high-grade lesion. In such cases, with the presence of low-grade dysplastic cells, you can diagnose the low-grade squamous intraepithelial lesion with ASCH. Another group is present here. Comparing to intermediate cells, there is a coarse chromatin pattern with hyperchromasia and increased NC ratio. There's a scant cytoplasm in these cells, and the atypia is more prominent comparing to the previous groups. Small sizes in some of these cells with scant cytoplasm, prominent NC increase in the NC ratio indicate a high-grade lesion in such a group. So from now and then, we can call this case as high-grade squamous intraepithelial lesion. We know that the highest grade is reported in a smear. A single cell is present here with a prominent increase in the size of the nucleus is evident, with a coarse chromatin, prominently coarse chromatin pattern. Hyperchromasia is also seen with an increased NC ratio. Beside this single dysplastic cell, another group is present here, which have small size with prominent hyperchromasia, and especially in this nuclear contour irregularity and irregular shape is present. All of these features are suspicious for a high-grade squamous intraepithelial lesion. Another small group is seen here, which shows similar features. Comparing to intermediate cell, there's an increase in the size. The size of these nucleus are about twofold of an intermediate cell, and also an hyperchromasia is present. The cytoplasm is dispersed in some of the cells, but in this one, we can say that there's an increased NC ratio and scant cytoplasm is present in this cell. So due to dysplasia, due to small size of the cells, with prominent increase in the NC ratio, a high-grade lesion should be suspected in such features. In a high-grade squamous intraepithelial lesion, some of the cells can be seen as single cells, as we see in the previous features, or they may form small clusters, and some of the clusters may have an syncytial appearance, like in this group. In syncytial-like groups, the cytoplasmic borders are indistinct, and especially they resemble the hyperchromatic crowded groups. In the center, the nuclear details are not well visualized, but at the periphery of these clusters, nucleocytoplasmic details can be well recognized. And when we focus on the periphery of this group, we see that these cells have hyperchromatic nuclei with irregular nuclear borders and increased NC ratio. But there's only a slight increase in the nuclear size in this group. With all of these features, this syncytial-like aggregates with prominent nuclear atypia, and with the presence of the single dysplastic cells, you can easily diagnose such case as high-grade squamous intraepithelial lesion. When you diagnose a high-grade squamous intraepithelial lesion in a case, careful evaluation of the case for the presence of the tumor diathesis is mandatory. And after careful evaluation of the background, we didn't find any tumor diathesis. The background is clean in this case, so high-grade squamous intraepithelial lesion is diagnosed in this case. And I will show you the follow-up of this case now. Here you see, firstly, the normal squamous epithelium that covering the cervix, but from this point, a dysplastic epithelium is present. Throughout the full thickness, there's a loss of polarity, hyperchromasia, increase in NC ratio is evident. Here, a SIM2 lesion, which is also called as high-grade squamous intraepithelial lesion, is present, and the cervical glandular involvement is seen here at this point, and SIN3 lesion is also present here, which involve the full thickness of the epithelium. Now, I will show you the next case. This is a conventional pap smear from a 69-year-old woman. I will show you two different areas. And beside the intermediate cells, we see highly keratinized cells with orangophilic cytoplasm. Keratinized cells can represent an non-atypical parakeratotic cells, or they may belong to an squamous cell carcinoma or low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesions. And to decide decide the diagnosis, we need to evaluate the nucleus of the keratotic cells. And when we look to the nucleus of these cells, we see that there's an increase in the size of the nucleus comparing to the intermediate cells. There's a prominent hyperchromasia with increased NC ratio and very scant cytoplasm. All of these features are suspicious for dysplasia in these keratotic cells. Due to small size of these cells with prominent hyperchromasia, prominent atypia, these keratotic cells, keratinized cells, are suspicious for an high-grade squamous intraepithelial lesion. But beside these small-sized keratinized cells, there's a bigger cell is present here. This cell have larger cytoplasm with slightly increased NC ratio with hyperchromatic nuclei. Such cell may belong to an low-grade squamous intraepithelial lesion too. Beside these atypical keratotic cells, keratinized cells, there are dispersed small-sized atypical cells too in the background. These small-sized cells have also enlarged nuclei with hyperchromasia, with scant cytoplasm. These dispersed atypical small cells with the keratinized cells indicate an high-grade dysplasia in a smear. The background is clean without a tumor diathesis, so high-grade squamous intraepithelial lesion with keratinizing features should be diagnosed in such a case. When you see such features, you need to evaluate the case for the presence of the tumor diathesis carefully. But after careful search, we couldn't find any evidence of tumor diathesis in the slide. Similar features were present throughout the slide. Atypical keratinized cells and single dispersed atypical cells, which have small size with scant cytoplasms, were seen throughout the slide. Also here, a fiber cell is present with a cytoplasmic tail, and this case was diagnosed as an high-grade squamous intraepithelial lesion with keratinizing features. And follow-up of this case showed an squamous cell carcinoma. I will show you this. And here you see the invasive solid islands of the tumor. But beside these tumor islands, the invasive tumor squamous cell carcinoma, here in this point, we see an SIN3 lesion, high-grade squamous intraepithelial lesion on the mucosa. And I will show you the last case now. Here we see a smear from a 35-year-old woman. The smear have a scant cellularity and single dysplastic cells are seen in the background. You can see here a good example for this one. And comparing to this intermediate cell nucleus, there's an increase in the size of the nucleus, approximately 4 to 5 times increase in the size of the nucleus is evident. Also hyperchromasia and slight irregularity in the nuclear membrane is seen. But the cell is not small, it has a large cytoplasm comparing to an high-grade lesion. So with presence of atypia in the nucleus, and cell that resembles an intermediate cell is suspicious for a low-grade lesion. With the presence of a single cell, you cannot call this case as low-grade squamous intraepithelial lesion. After careful search of the slide, if you cannot find any more dysplastic cells with these features, with the single dysplastic cell, ASCUS may be preferred for such a case. But after careful search, besides this one, we have also found some FIF cells with dysplastic features. For example, these two ones also have enlarged nuclei with hyperchromasia, and also in this cell there's a nuclear contour irregularity, and the size of these cells are smaller than the previous one. They have scant cytoplasm comparing to the previous one. So with the presence of dysplasia, with the size of these cells, and higher grade lesion is suspected with these features. Other two dysplastic cells are seen here. In this one, a highly increased NC ratio is evident with coarse chromatin pattern. This is suspicious for a high-grade lesion. But in this atypical cells, in the cytoplasm, there's a small vacuole, and in the center, a small droplet is present, which resembles an presence of mucin in a cytoplasm. So a glandular differentiation should be taught in such picture, but also you need to remember that artificial changes may be seen, may show similar features. These two atypical cells are lying beside an proteinous material, broken down blood elements and a proteinous material clinked to these two atypical cells, and this is called as clinking diathesis, and this feature is suspicious for invasion in a smear. And another dysplastic cell is seen here, comparing to this intermediate cell or this one. There's an enlarged nuclei with hyperchromasia, and also irregularity in the nuclear membrane is present. The cytoplasm is scant. There's an prominent increase in the NC ratio. Due to this prominent nuclear atypia with the small size of this cell, with prominent increased NC ratio, indicate a high-grade lesion. But when the atypical cells that are suspicious for an high-grade lesions are limited in the smear after careful search, or if they have subtle features, the preferred diagnosis for such cases should be ASCH. But also beside these single dysplastic cells, a few dysplastic cells, we see blood in the background, which is suspicious for an invasion. Let's look at the follow-up of this case. Follow-up of this case showed an SIN2 high-grade squamous intraepithelial lesion, as you see here. Here we see the normal squamous epithelium, and now from now on then, and dysplastic lesion is starting, which characterized with loss of polarity and increased NC ratio, which involved 2/3 to full thickness of the epithelium. And this was my last slide. I want to thank you for attending this presentation.
In this session, I will present you 3 cases. The first case is from a 55-year-old woman. She has HPV 51 positivity. You see Shurpad preparation. We see intermediate cells and some hyperchromatic crowded groups like this and this, and also some hyperchromatic single cells in the background or small groups. This hyperchromatic group is tightly packed. We see high NC ratio, hyperchromatic nuclei, and the nuclei are round. Another tightly packed group here. We can see that the cells are round, have high NC ratio, and heterogeneous chromatin pattern. Another similar group is seen here. And also here, some cells have elongation, but mostly the cells are round. When we see this kind of groups, we look for high cell cells because these groups resemble high cell with endocervical glandular involvement. The cells are round, not columnar, so we don't think that this is an AIS, adenocarcinoma in situ. We look for high cell cells in the background. We see these hyperchromatic round cells or single small groups, single cells or small groups. And this single cell. Again, another single cell here, and the hyperchromatic group cells are seen here. These cells are high cell cells with high NC ratio, hyperchromasia, and heterogeneous chromatin pattern. So we diagnose this case as high cell with endocervical glandular involvement. And after that, the patient had lip biopsy. Here you see the lip biopsy. We see hyperchromatic crowded stratification in squamous epithelium. Hyperchromatic squamous cells with stratification, and also we see mitotic figures. This is high cell, there is no invasion. And also we see endocervical glandular involvement here. These are normal endocervical cells, and this is endocervical glandular involvement. And also here we see endocervical glandular involvement. There is no sign of invasion here. High cell in the squamous epithelium and endocervical glandular involvement. Okay. My second case is a 38-year-old woman. This is her routine control pap smear. You see Shurpad preparation. We see superficial cells and also intermediate cells. There are lots of hyperchromatic crowded groups in the background, and also single cells or smaller groups are seen. First of all, I want to show you that this is a normal endocervical group with honeycomb arrangement. You see the nuclear size. And here there is another group with nuclear enlargement and some distinct nucleoli. Here we see that hyperchromatic group. There is nuclear elongation and stratification and heterogeneous chromatin pattern. Nuclear stratification, elongation, heterogeneous chromatin pattern, and some distinct nucleoli. Again, here we see these nuclear elongations, stratification. This is different from the previous case, which I told you before. The high seal with endocervical glandular involvement, there the cells were round and very hyperchromatic. These cells are more elongated and there is stratification. Again, you can see stratification and also heterogeneous chromatin pattern. Same morphology, cytomorphology is seen here. These are smaller groups with nuclear elongation. And these are round cells with heterogeneous chromatin pattern. And these are normal endocervical cells with honeycomb arrangement. Okay, similar cells are seen here. And also, we can say there is feathering at the periphery of the group. You can see the stratification and heterogeneous chromatin pattern and nuclear elongations again here. And also hyperchromatic three-dimensional group is seen here. You can see this feathering at the periphery of the group. You can see that the background is clean. There is no tumor diathesis. So with these findings, we reported this case as adenocarcinoma in situ. And the patients had leaf biopsy. Here, and also endocervical and endometrial curettage. Here we see the leaf material. We see the endocervical glandular epithelium, very hyperchromatic cells from this magnification. Okay, and When we look closer, we can see hyperchromasia, nuclear elongations, and stratification, and also many mitotic figures. Mitotic figures are seen here, here, here. You see elongation of nuclei and also hyperchromasia and stratification. There is no sign of invasion, and we reported this case as adenocarcinoma in situ, endocervical adenocarcinoma in situ. I will show you P16 staining. Here you can see cytoplasmic and nuclear strong positivity for P16. So this case was endocervical adenocarcinoma in situ. The third case is from a 66-year-old postmenopausal woman. She had endometrial mass. It was 8 centimeters in largest diameter, and it invades cervix, vagina, and rectum wall. And this patient had conventional pap smear. As you can see here, it's a hypocellular smear. We see many inflammatory cells in the background. You can see that in the background, there are inflammatory cells and also watery tumor diathesis. We see hyperchromatic group here, and also another group here with larger cytoplasm. Pleomorphic cells are seen, and these are hyperchromatic cells with high NC ratio. Here we see this glandular epithelium with delicate cytoplasm and round nuclei. And also here another hyperchromatic group with glandular-like formations, high NC ratio, and another hyperchromatic group is seen here. You can see the background, dirty tumor diathesis. There are many hyperchromatic groups, and here you can see round nuclei, but we can't see the nuclear or cytoplasmic detail here because they are three-dimensional groups. Here, another group is seen with high NC ratio, round nuclei, and distinct nucleoli. Okay, another similar group is seen here with distinct nucleoli and scanned cytoplasm. There are also many macrophages in the background. Okay. And another glandular-like formation is seen here. We see this vacuolated cytoplasm and another hyperchromatic single cell here, another hyperchromatic cell group here. Yes, we see the heterogeneous chromatin pattern and also some distinct nucleoli. And these delicate cytoplasm. So this case was reported as adenocarcinoma, NOS. There is a watery tumor diathesis in the background. And then the patient had vaginal biopsy because the endometrial mass invaded cervix and vagina. Here we see the tumoral lesion. We see papillary configuration of the tumor. The cells are hyperchromatic. Some of them have vesicular nuclei and distinct nucleoli. Also, you see heterogeneous chromatin pattern. This is a high-grade tumor with high mitotic activity and nuclear pleomorphism. Similar to the cytology specimen, we see hyperchromatic groups, these single hyperchromatic cells, and also these large vesicular nuclei with distinct nucleoli. And also, this tumor had necrotic areas. So we performed immunohistochemistry for the case. These tumor cells were strongly and diffusely positive for p53 and p16. And estrogen receptor was negative. Monoclonal carcinoembryonic antigen was negative. And napsin A was negative. And the tumor is diagnosed as high-grade serous carcinoma. Thank you very much for your attention.
Good afternoon, everyone. I'm Dr. Çisal from Koç University. First of all, thanks to the committee for inviting me. And in this session, I'm going to talk about HPV testing for cervical cancer. Cervical cancer is responsible for too many deaths. Approximately 12,000 new diagnoses are reported every year, and about 4,000 women lose their lives to cervical cancer annually. And cervical cancer is highly preventable. With vaccination, screening, and early detection, almost 100% of cervical cancer cases can be prevented. And vaccination against HPV provides effective protection against the main high-risk HPV types. Regular screening, such as pap tests, can detect precancer changes early, allowing for timely intervention and treatment. So let's look about the incidence rate of cervical cancer. As you can see in this graph, it's very low compared to the other countries. And similarly, the mortality rates from cancers are at levels that many countries aim to achieve with vaccination. If we take a look closer to the data of Turkey, which I obtained from the HPV Information Center, estimated annual number of cervical cancer cases about 2,500, and annual number of cervical cancer deaths estimated 102,000. And if you examine the routine of cervical cancer screening in Turkey, since 2014, HPV testing has been conducted. So anyone can get HPV. Women over the age of 30 are less likely to clear HPV infection compared to the younger women. Persistent HPV infection in older women increases the risk of developing cervical cancer. The risk of developing cervical cancer increases as women reach the age of 30 and beyond. And regular screening and follow-up are crucial for early detection and intervention. And the development of cervical cancer typically occurs over a period of 10 to 20 years. Even if a woman is no longer sexually active, periodic pap tests are still necessary for early detection. Women should continue to have regular pap tests as part of their healthcare routine, regardless of sexual activity or age. So, what is HPV? HPV is a group of small DNA viruses. And these viruses are highly specific to their respective species and have co-evolved with their hosts. The papillomaviridae family consists of approximately 450 human papillomavirus types, which are categorized into 5 phylogenetic genera: alpha papillomavirus, beta papillomaviruses, gamma papillomaviruses, mupa papillomaviruses, and nupa papillomaviruses. And HPVs infect specific regions of the cutaneous epithelium, and sometimes are also infect oral and genital mucosal epithelium, such as alpha papillomavirus family. And many HPV infections are asymptomatic and part of the normal skin flora. Some of HPV types cause benign lesions, warts, or papillomas, while others can progress to cancer after long-term infection. And the classification of HPV types, species, and genera is based on the nucleotide sequence of the L1 gene, which encodes the major capsid protein. And each HPV type has less than 90% nucleotide sequence similarity in the L1 gene compared to the previously identified types. In this figure, oncogenic HPV shown in red, and probably or possibly oncogenic viruses shown in orange. And HPV vaccines are indicated with a black dot. And this figure belongs to the alpha papillomavirus family. And the majority of the HPV infections are temporary and become undetectable within 12 to 24 months. However, in some cases, HPV infection persists, increasing the risk of developing precancerous condition. We still don't know which cases will progress to cancer and which ones will not. However, cervical cancerogenesis refers to the complex process of uncontrolled cellular division, and it involves HPV gene integration with other cellular changes and epigenetic factors. So, how is the infection and replication? The human papillomavirus enters the cervix through a small tissue abrasion. And these microfissures provide an entry point for the virus to infect the basal cells of the cervix. After entering the target cell, HPV has the ability to either remain in a latent state within the nucleus or initiate replication. In some cases, HPV establishes a persistent infection into the host cells, while in others, it undergoes active replication. During the replication phase, HPV synthesizes new viral particles within the superficial cells of the cervix, and these infective viral particles are subsequently released, allowing the virus to spread and potentially infect other cells or individuals. And the oncogenic potential of high-risk HPV is linked to the regulation of viral transcriptional factors. For example, HPV-16, a high-risk HPV type, can integrate its genome into the host genome, contributing to the development of cervical carcinoma and HISO. And this integration combined with this regulation of E2 protein, as a result of the overexpression of E6 and E7 protein occurs, disrupting cellular apoptotic mechanism and promoting viral carcinogenesis. However, it's important to note that the overexpression of the E6 and E7 alone is not sufficient for cancer development, as other genetic and epigenetic factors also play a role. In addition to their role in immune evasion and degradation of important cellular proteins, the E6 and E7 protein also induce telomerase activity. So let's look closer to the E6 and E7 protein. E6 protein interacts with the cellular tumor suppressor protein P53, leading to its degradation. In normal condition, P53 plays a crucial role in regulating cell growth and preventing the formation of tumors. However, when E6 degrades P53, this control is compromised. The degradation of P53 allows infected cells to bypass the normal mechanism that regulates cell division and cell death, leading to uncontrolled cell growth. And the E7 protein, on the other hand, interacts with the cellular tumor suppressor protein, RB, and RB is responsible for controlling the progression of the cell cycle and inhibiting the excessive growth of cells. When E7 interacts with the RB, it disrupts its function, resulting in the loss of cell cycle control and further promoting uncontrolled cell division. The combined effects of E6 and E7 result in the dysregulation of cellular process, increase the cell proliferation, and the accumulation of genetic alteration. Over time, this genetic alteration can lead to development of precancerous lesions and, in some cases, progress to invasive cancer. So, how can we detect infection? Traditional pap smear remains a valuable choice in some settings, and regular pap screening decreases cervical cancer incidence and mortality by at least 70%. However, cervical cytology has limitations in terms of reproducibility and sensitivity around 60%. And recent advancements in understanding the role of HPV in cervical neoplasia have led that primary HPV-based screening is an alternative option. So, for a patient at the doctor's office, an HPV test and the pap test are done the same way by collecting a sample of cervical cell with a brush. And the new American Cancer Society guideline offers that 2 HPV tests have been approved by the FDA for uses as a primary HPV test, meaning it is not part of an HPV PAPCO test. Other HPV tests are approved as a part of HPV PAPCO test, and the ACC recommends cervical cancer screening with an HPV test alone every 5 years for everyone with a cervix from age 25 until age 65. If HPV testing alone is not available, people can get screened with an HPV co-test every 5 years or a pap test every 3 years. And this is a Lancet publication from 2014. A total of 176,464 patients were included, and the result of this study showed HPV-based screening prevented more invasive cervical cancer than did cytology. And the different screening protocols used in these 4 studies did not affect efficacy of HPV testing. So what is the difference between HPV test, pap test, and the HPV PAPCO test? Actually, the high sensitivity of HPV tests, like 95%, makes it ideal for primary screening. And HPV DNA test reduces the risk of cervical cancer by 60 to 70% compared to cytology screening. A negative HPV test provides better reassurance and allows safe prolongation of screening interval. And the HPV test is more effective in detecting glandular lesions and precursors of adenocarcinoma. HPV testing is more suitable for screening HPV vaccinated populations too. So, what are the molecular applications in cervical cytology? Molecular markers can be evaluated in purposely sampled cervical cells, residual cellular to liquid buzz, cytology, or already stained pap smears. This slide is very important. I have listed several ancillary techniques that can be used for triaging HPV positive women. Let's discuss what each technique entails and what its information provides. HPV molecular markers, HPV genotyping. This technique identifies specific HPV types present in the infection, distinguishing between high risk and low risk type. mRNA testing, it detects the expression of HPV E6, E7 oncogenes, which indicates active viral replication and a higher risk of cervical neoplasia. molecular markers involved in cell cycling, hyperexpression of p53, elevated levels of p16 protein suggest the presence of high-risk HPV and cellular changes associated with neoplastic progression. HPV viral load, quantification of viral DNA can indicate the persistence and activity of the infection, and detection of HPV integration into the host genome is associated with a higher risk of cervical intraepithelial neoplasia and cancer. Molecular markers related to epigenetic changes, methylation of human and viral genes, aberrant DNA methylation patterns can serve as indicators of cancer development and progression. And microRNA, differential expression of specific microRNA can be associated with HPV-associated carcinogenesis and may serve as potential biomarkers. And what about cervical microbiome? It is a potential biomarker, and the composition and diversity of vaginal microbiome can influence HPV infection and risk of cervical neoplasia. Analysis of the cervical microbiome may provide additional insights and potential biomarkers for disease progression. And the purpose of utilizing these ancillary techniques is to increase the specificity of HPV testing and identify high-risk individuals who may require further investigation or intervention. By incorporating these molecular markers and microbiome analysis, healthcare providers like us can better tailor patient management and provide appropriate care for HPV-positive women. Techniques for HPV genotyping, we already talked, but there are several methods available to detect specific HPV types in a biological sample, such as PCR with generic primers, hybridization with specific probes, or sequencing. All of these techniques help identify the presence of specific HPV types in the sample. And this is very important. Laboratories involved in HPV genotyping should participate in external quality control programs to ensure the accurate and reliable results. So, classification and general characteristic of current available commercial molecular HPV tests. In 2020, there were 254 distinct commercial HPV tests and over 425 test variants available globally. And the distribution of manufacturers of these tests varied by continent and country. And the Asia-Pacific region, particularly China, was the leading producer of HPV tests, accounting for almost half of all distinct tests. And out of the 254 distinct HPV types, only 2 targeted non-alpha papillomaviruses, while the remaining tests focused on different alpha papillomavirus types, including clinically relevant types with carcinogenic potential. And we know 12 types, known as ER 2009, high-risk HPV types are classified as carcinogenic by the International Agency for Research on Cancer, including HPV 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, and 59. These variants were considered if they were technologically similar to the original HPV test, but targeted different HPV types. For example, the Papillus HR HPV genotyping kit was considered a distinct test, while the Papilloplex all HPV genotyping kit was considered a variant of as it targeted different HPV types. So, various types of HPV tests are available for screening and detection of HPV infection. And we can categorize into different groups based on their technology and the types that they target. High-risk HPV DNA screening tests detect clinically important high-risk HPV types without distinguishing individual HPV types. And the high-risk HPV DNA screening tests with concurrent partial genotyping allow screening for specific high-risk HPV types such as HPV 16, 18, or 45. And the HPV DNA full genotyping tests enable to determination of all high-risk HPV types in a single test commonly used in research and surveillance. And the HPV DNA or a group-specific genotyping detects specific subset of high-risk HPV DNA. And the high-risk HPV E6, E7 mRNA test detects mRNA of important HPV oncoproteins, showing higher clinical specificity compared to the DNA-based assay. And in situ hybridization, HPV test allows simultaneous detection and localization of HPV infected cells. And HPV DNA test targets single cell HPV types are available, including those associated with skin cancer or skin warts. With such a wide variety of HPV tests available, it is important to know which ones to trust and consider when making a purchase. There is no general consensus on how to validate the performance of HPV tests in the HPV community. Validation of HPV tests involves assessing their analytical performance, including sensitivity, specificity, reproducibility, and clinical performance in detecting high-risk HPV types associated with cervical cancer. And validation studies typically involve comparison with gold standard reference method and the large-scale testing on clinical samples to evaluate the test performance in real-world settings. And those are the main validations area. The WHO HPV laboratory network and the Vulcan project play critical roles in providing standardized protocols. FDA regulation ensures HPV tests meet the stringent criteria for accuracy, reliability, and clinical performance before they can be marketed. And Meyer HPV assay have undergone extensive validation studies demonstrating their efficacy in detecting and genotyping high-risk HPV types in various populations. And when we talk about that, there are 7 main groups of commercially available HPV molecular tests in global market. And in this table, you can see, for example, high-risk HPV DNA screening tests. There are 40 HPV distinct tests, but a few of them validating using the methods I mentioned earlier, like in here. As you can see, there are very low number of tests validated using the methods I mentioned. And those are the FDA-approved tests. There are 4 companies involved with the same offering DNA screening tests, such as Kiagen, HC2, and Hologic Servista, while others like Roche Cobas and BD OnClarity provide genotyping capabilities. And especially Cobas and OnClarity HPV are those tests that you can use this HPV screening. And Cobas has the advantage of being compatible with both TeamPrep and TruePrep, whereas BD OnClarity is specifically designed for TruePrep. When we examine the details of the FDA-approved test, Optima stands out as the only one that targets RNA, while others target DNA. BD and Optima specifically target E6, E7 proteins, whereas Cobas targets L1, and Servista targets both E67 and L1. And there are, of course, other assays using RNA too. And all 4 FDA-approved commercial HPV tests demonstrate over 90% sensitivity and specificity based on comparative HPV assay studies. And in our lab, we have the OnClarity test, and we can able to detect 14 high-risk HPV genotypes and report up to 9 results, like 6 common HR HPV types. We can able to report them individual genotyping, and other high-risk HPV genotypes reported by group like 30, 30, 58, 35, 39, and 68, something like that. And BD OnClarity provides accuracy of results to elevate our performance 2. It's a DNA-based assay, and it targets E6 and E7, and it's validated for vaccinated women too. And video on-clarity assay meets the international criteria for primary HPV screening according to my criteria, and FDA approved for primary HPV screening and Valgan protocol, which we talked the previous slides. So when it comes to the validation, and we talk about that there has been significant increase in the number of commercial available HPV tests. However, many of these tests lack proper validation and have limited published data on their analytical and clinical performance. Out of the 254 HPV tests on the global market in 2020, a large majority, like 82%, lacked any published evaluation in peer-reviewed journals, and over 90% were not evaluated according to the consensus requirements for safe clinical use. And it is essential for manufacturers to appropriately validate their HPV test and participate in validation initiative and quality control programs, because this will ensure the reliability and accuracy of the test and promote their safe and effective use in clinical settings. So please check the test before you purchase an HPV test. Is it validated, or is it have standard agreed with HPV community? So this is my last slide. What are the challenges in the laboratory? Sample integrity. Maintaining the integrity of the sample is crucial for reliable HPV testing. Proper collection, transportation, storage protocols should be followed to prevent sample degradation and ensure accurate results. And the test accuracy and sensitivity, this is very important, because we are aiming to minimize the false positive and false negative results, improving the effectiveness and screening and diagnosis. Quality control is really important. Contamination is really important, because contamination poses a significant challenge in HPV testing. Stringent measures should be in place to prevent cross-contamination between samples, minimize the risk of external DNA contamination, and ensure accurate and reliable results. Of course, laboratory efficacy is important too. And by addressing these challenges, laboratories can enhance the quality and reliability of HPV testing, leading to improved patient care and better outcomes. Thank you for listening.